plans for expansion of the drug-resistant TB management and not take into account mental health is probably doing not a nice job. Of course, one of the key problems that we have in TB is adherence, and obviously it's not easy being adherent to a toxic regimen, lengthy regimen, if you are sad or depressed, right? So I'm really happy that these kind of symposiums, which probably are not the most overcrowded, but they are certainly one of the most important. Yeah.
Good afternoon, everyone. It's my pleasure to meet you this afternoon here, this conference, and I think we have quite an exciting topics to share with you from different perspectives, and we will be discussing mental health implications during TB treatment, and also how TB impacts mental health detection and also management in different settings. And we have here very experienced speakers today, and now I would like to invite the first speaker, who is Dr. Samson Haumba. Dr. Samson has a very long experience as a medical practitioner, as well as he has a experience as a healthcare manager and also public health specialist with in-depth knowledge and experience of TB, HIV, AIDS within different donor-funded programs. Today, Dr. Samson will be presenting palliative care and how health systems can deal with mental health issues which arise during palliative care of TB patients. So, Dr. Samson, so the floor is yours. Thanks.
Good afternoon, ladies and gentlemen. I'm presenting on the mental health aspects of palliative care in MDR and XDR TB patients. I'll start by declaration. I don't have any conflict of interest. And that is my presentation outline. I'll give a brief background, and then we'll look at palliative care in the context of MDR, XDR TB, the mental health issues, as well as how palliative care can be used to manage mental health aspects of MDR TB. And then we'll have some conclusions. So as a way of introduction, and as the chair has mentioned, the psychiatric syndromes, which are many, but if we just highlight depression, anxiety, and delirium, are usually underdiagnosed and underreported, but they do exist. From many studies, they say that at least one woman in 5 will have a mental health problem in the course of their life. One man in 10 will have a mental health problem in the course of their life. And therefore, even in the context of the patients, the MDR TB patients, psychiatric syndromes are usually rarely recognized because sometimes they also overlap with the medical conditions. So these symptoms affect the health, they affect the quality of life, as well as the ability to respond to the disease symptoms, because sometimes the disease symptoms of MDR TB can also sometimes overlap with the mental health aspects. For instance, issues of feeling low, mood changes, and so forth. So sometimes they are interpreted as part of the medical conditions. So in the management of MDR TB patients, sometimes differentiating the mental health aspects of the patient might be difficult from the MDR TB aspects of the disease. And untreated psychiatric symptoms affect the achievement of the goals of quality of management of patients. I will briefly give the definition of palliative care as defined by WHO, because palliative care is widely accepted as a best practice for managing chronic conditions. And mental health aspects of chronic diseases is one of the chronic conditions that we can consider. The definition of palliative care is an approach that improves the quality of life of patients and families facing problems associated with life-threatening illnesses. And we know that MDR-TB and XDR-TB can potentially be life-threatening. And it also involves the prevention through early diagnosis, early identification, as well as impeccable assessment and treatment of the problems, physical, psychological, as well as spiritual. There are many international guidelines relating to palliative care in the era of DRTB, and I just highlight a few here. In 2010, the international guidelines of on palliative care for DRTB that emphasize access to palliative care for adults and children as a human right and as something that promotes human dignity. Then the WHO, the World Health Assembly resolution on the public health strategy and palliative care, it also emphasizes admission of palliative care or implementation of palliative care for our patients as part of human rights. And then we also look at WHO guidelines of resolution of 2013, strengthening palliative care, as well as 2014. So there are many of these guidelines that have recommended that we include palliative care in DRTB treatment and management. However, it's not being done as normatively as it should be done. And that's why we are discussing it here. So the principles of palliative care are based on the ethics framework of human dignity, of justice, and person-centered care. And this is accomplished through the prevention and relief of suffering through early identification, assessment, and treatment. The benefits of palliative care include improvements in symptoms, relief, and reductions in pain and suffering, high levels of satisfaction by family members, improvements in the overall quality of life, as well as associated significant reduction in costs, as well as hospital admissions. But above all, it improves the overall survival for the patients. And in terms of the structure for palliative care, we know that the structure and process involves interdisciplinary and multidisciplinary assessment of a patient and family. It includes physical aspects of care, which will include pain, management of other symptoms, as well as side effects. It will include the cultural aspects of care, which aims to meet the cultural specific needs of patients and families. It will include the psychological aspects of care. That includes assessment for the psychiatric issues and managing those psychiatric issues. It includes the spiritual and religious aspects of care, as well as the ethical and legal aspects. So we'll look at two of these syndromes, anxiety, to start with. I know that we all get anxious at one point or another. However, in the context of MDR, XDR, TB, we need to be careful that we are really assessing those bothersome symptoms that will include psychological distress. Patients will have concerns and fears after the diagnosis of TB or MDR, TB has been made. And we also need to make sure we are assessing the previous coping mechanisms for anxiety. During examination, of course, we need to look at the condition of the patient which might be contributing to the anxiety. And sometimes in the anxiety, the patients may develop high blood pressure, they are tachycardic, and they are apprehensive, jittery, and so we need to look at all those aspects in the management of the patient. In terms of managing anxiety, we need to make sure that we are trying to treat all the underlying problems, and if the problems are associated with medication, we should be able to discontinue the medication. Then I'll also talk briefly about depression, which normally comes because of the diagnosis that has made, but also sometimes as an effect of the drugs that the patients are taking. And in examining the patients, we need to be able to ask certain questions, whether they are feeling low or they have a depressed mood, because we know that if patients are feeling hopeless, then there's high tendency to suicidal tendencies. But we should also need to look at the interest in their environment, interest in things that normally would give them pleasure, which they are no longer feeling. So we need to do a thorough assessment of the patient, and we should be able to provide remedy for some of the conditions that the patient is feeling. And there are a number of steps, but I will not go through all the steps, but performing an initial thorough assessment of the patient, establishing effective communication so that the patient is able to open up and discuss with you the psychological issues, and then considering the interventions that might help the patient overcome the depressive symptoms, as well as evaluating for major depression, because we know that major depression could lead to suicide, and some patients develop psychotic symptoms that needs to be managed medically and sometimes through referral to specialists. And then, of course, we can use the antidepressants, but we need to use them appropriately. I will just highlight that in the assessment of the patient, we could have pre-existing psychiatric conditions as well as the new psychiatric diagnosis, and that is very important that we do that assessment. Like I mentioned, a patient could develop MDR-TB but already has existing psychiatric diagnosis, and that needs to be managed appropriately. I highlight two studies here which highlight that there are a number of patients who develop TB, MDR-TB with already existing, pre-existing psychiatric symptoms. In this particular study, 16% of the patients already had pre-existing psychiatric diagnosis. And in another study, 52% already had pre-existing depressive illnesses. Now, those need to be managed in addition to managing the TB. Otherwise, the outcomes of the patient will be significantly affected. So in conclusion, mental illnesses, including depressive symptoms, demand attention when we are managing the patients. And the patients normally feel these symptoms either as pre-existing or as a result of the medication that we give them. And if we don't manage them, then the psychiatric symptoms actually provide a bigger burden to the patient than even the TB itself. So routine administration of baseline mental assessments should be included in our assessment of all patients who are initiating MDR-TB. And we should continue regular monitoring of the mental status in order to improve the quality of life of our patients and put in place appropriate interventions. Thank you. I want to acknowledge those institutions and organizations.
Thank you very much for your presentation. Do you have any question or comment? Yes, please.
Thank you very much for that presentation. I'm Darcy Richardson from the United States, and I was just, it strikes me in thinking about mental health in particular and some of the other comorbidities that we talk about at this conference, that this really requires much more of a team approach and engagement of other providers. And I was just wondering if you could talk a little about, in your experience, who you have engaged to provide mental health screenings and then to provide ongoing services. Are you engaging psychiatric services? Are you training other staff to do that kind of work?
Thank you very much. Yes, it's a team approach. And really the recommendation is that any health worker should be able to do the assessment and then refer as appropriate. Psychiatrists come in, but normally at the very end. But there is also need to interest the psychiatrists in the mental health conditions of our MDR-TB patients. As you know, many of the specialists sort of shun the MDR-TB patients. So it is sort of a stepwise inclusion of the various specialists, but we should start with the best healthcare workers who are managing these patients to know at least the basic screenings for the patients before referral if they can't manage.
Okay, any more questions or comments? Okay, thank you very much, Doctor. So now it's my pleasure presenting to the next speaker, who is Hala Hassim Al-Mosawi, who is a public health specialist with 19 years of experience in health workforce development, capacity building, system strengthening, and monitoring and evaluation at all levels. For several years, she has worked for the University Research Company in the field of headquarters and is currently the Senior Director of the Technical Support for Center for Innovations and Technology. As well, she has been working in more than 12 different countries, and from 2014 to date, she serves as the Technical Director for many of these DOS-funded programs under the Biological Engagement programs. So, thank you very much for coming. The audience is yours.
Thank you. Good afternoon, everyone. I'm not sure if you hear me. Okay, good now. So the next 10 minutes, I will be talking about the patient-centered care approaches to reduce stigma to TB. And it's a very interesting topic, as well as all the topics in this session, to focus on two important but maybe neglected areas: stigma and mental health problems, most importantly among TB patients. So, as you all know, for TB, despite being curable, preventable, and treatable, it's a reason, or it's a leading cause for mortality, and with a prevalence rate more than 90% mortality rate in resource-limited countries and low and middle income countries. So in this presentation, we'll talk about stigma in general, briefly about some definitions related to stigma, then association between TB and chronic or common mental health disorders. Then we'll also present patient-centered care model, or a human-centered design that's designed by URC to address the stigma problem. So stigma, as defined by Goffman, is it's a complex social process that happens when elements of labeling, separation, and loss of status occur in a power situation that allows them. And in many settings, and all settings, TB patients experience psychological, social suffering, and also impact their access to medical services, and it's a key barrier. It's a key barrier besides all the biological, cultural, and other economic barriers to quality of life in TB management. According to Goffman, he distinguished two types of stigma to TB, as well as other subcategories. One, it's enacted stigma, which mainly concerns with discrimination. Usually stigma and discrimination, two terms used interchangeably, but there is a slight difference. So enacted stigma, it's due to social inferiority, and where you can see people, other people or the community, other individuals surrounding the TB patients, they run away from TB patients. The second type of stigma is the perceived or internalized stigma, which is a sense of inferiority. This is for the patients where they hide their TB status. They don't seek TB care and treatment because of they are ashamed of having TB. He further subcategorized the stigma into other subcategories, which is mainly the experienced stigma when the TB patients or the people infected with TB, they experience that stigma, but also the perceived stigma as well as the anticipated stigma. So, as you all know, the social determinants of health, it's a package of institutional, community, as well as individual elements and factors, attitudes that impact access to medical and health services. So stigma usually impacted, shaped, or influenced by these factors and attitudes. And there is geographic as well as cultural variation in the explanation for why TB is stigmatized, whether it's related to the lack of knowledge, like they don't have the knowledge about the routes of TB transmission or risk of transmission, contagiousness of the disease itself. So beside all these factors, it's a key barrier. We studied for this presentation specifically many researchers and studies, over 36 studies. This specifically stigma as well as mental health, common mental health disorders in association with TB not addressed much in terms of assessments or in terms of interventions, like packages specifically designed for these two issues. Samson, he talked about the key signs as well as key association between TB and common mental disorders. Will not go into the details, but you all know that there is a growing problem. There is also interest in the comorbidity between mental health and infectious diseases in general, including HIV mainly, that varies between 20 to 30%, particularly in developing countries. But this association has been described in one of the studies as association between TB and common mental disorders, where approximately 40 to 70% of TB cases have been found to have an anxiety or depression. And I think Samson, he presented two of these studies, specifically those linked to HIV infection as well. So in the next slide, I believe on the slide after that, we'll show you some data from these two studies. So in general, 5 types of mental health problems associated with TB. Some of these problems related to the psychological reaction to the diagnosis and the treatment, so the fear, then psychiatric side effect from the TB medications, physiological consequences of the disease of TB, and emergence of mental health issues while they are taking the medication, or also the other thing is the comorbidity as a result of shared risk. Many studies focused on, as well as presented in very interesting data and findings related to the key challenges facing whether the institutions, but also the patients with both morbidity, TB, and mental health issues related to under or misdiagnosis, also no integration. In many countries, there may be some guidelines for both, but not integrated into standard protocols. For stigma, as well as the mental health disorders, in many countries, especially in low and middle income countries, it's a low priority. It's not a priority to focus on mental health issues, specifically among TB or patients with infectious diseases. Then, of course, the limited evidence base for best practices. So these two tables from one of the studies, I think this is a study conducted by Rutgers University. These are interesting tables, looked at the association between the mental health disorders, TB, but also the outcomes for that. Key outcomes, delays in seeking care, delays in seeking diagnosis, as well as adherence to treatment, drug resistance problems, as well as treatment default. The second table illustrates the comorbidity, the prevalence, tuberculosis and depression, where you can see there is like prevalence of 46 to 72% depression and anxiety among patients or individuals with TB. So causes of stigmatization, it's it's just unclear, in addition to the geographic and cultural barriers and cultural factors, whether inadequate information or lack of knowledge and information about TB. But both of these lead to poor information that worsen the stigma and discrimination. In general, TB patients, they face many challenges. Some challenges or barriers related to healthcare in general, like poor healthcare, confidentiality, availability of the information, then access to healthcare, but also key social barriers related to stigma by the community and by the people surrounding them. So what can we do about stigma? This is a cycle that we designed based on some studies that we reviewed. So as you can see from as a stigma cycle, it starts with the perceptions of the riskness of the disease, then the response of the community as well as the institutions, whether there is a support for those people, then once they have this, they develop the self-stigma, then they start lack engagement. They don't engage in the treatment, or whether the institutions and the facilities providers don't have that support to engage them into the treatment. But in the end, the outcome will be poor health outcomes. So in general, not much about assessing the impact of TB and MDR-TB, whether social, economic, and psychological, with a specific focus on stigma. What can we do about that? Same thing with the support. What kind of support in terms of institutional as well as community capacity and response, then monitoring and evaluation. So this is a model designed, we designed this model, but also we designed this model as a human-centered design. We put the TB patient in this model. We can put any other, because the people are in the center of our design. So we look at various levels, we look at various factors that influence, impact the care to, in this case, to TB patients. So when we look at the household for stigma, what can we do? For example, parents, kids, spouse, siblings, others, to provide social support, mental health support. But then when you look at the community, you have the NGOs, you have the religious leaders, you have the community leaders, you have many support that can contribute. So then the third layer, which is the health facility, you have also the providers as well as the system. What can we do for each one? Then also we have a package of interventions for each one, means that there is a role for each of the these levels, but also the factors, players to play to support TB patients when it comes to social support. Government also play a big role in that, whether it's the Ministry of Health, but also other ministries, social affairs or others. So they play a role. Here it's more illustrative about who should be involved, but we can expand on that, whether it's ministries when it comes to research, whether it's other institutions when it comes to policies, regulations, so any other players that should be involved in this one. Same thing with the other sector, which is the supply that comes from both sides, the government, but also the private sector. NGOs, community, insurance, others, what they can do to address the stigma in TB patients. So in summary, many interventions have been designed in many countries. We looked at many countries. We reviewed some interventions, I think, implemented in Zambia, in Nicaragua, in South Africa, in many other countries, specifically stigma and TB. Many of these programs suggested or currently implementing some education and support programs for healthcare workers, individuals with TB, but those at risk community members. Another interventions where I think this is in Zambia, TB clubs to offer social support, where you have TB patients, they come together with the TB supporters for social support. They get help with the transportation to the clinic, encourage the treatment. They share their, especially if they have some mental health disorders or problems, then also they get some monitoring for treatment side effects and encourage TB screening among other at-risk community members. Patient-centered home visits is another approach or interventions in many countries to know better the social networks, where we highlighted in our model the social network for the patients at the household level, but also at the community level, then identify the strengths and weaknesses of the network and plan the activities to support the patient. Interventions focused specifically on mental health programs, where integration is very important, which is missing in many programs, to be integrated within TB control programs, and efforts should be made to increase the awareness about the high rate of the mental health disorders in TB patients and the implication of the mental health disorders, as well as the stigma for treatment outcomes. There is a need more for population-based cohort studies to better understand and assess the association, but also investigate the relationship between the mental health disorders, stigma to TB, to establish the direction of casualty, as well as one interventions not mentioned here, but also the role of the community, media, and social awareness. So these are the references, and thank you very much.
Please, any question, comments?
Thank you very much, Doctor, for the excellent presentation. My name is Dr. Anthony from KNCV. I listened very carefully to your presentation, but I did not hear you referring to the gender aspect, how the stigma affects different genders differently, if any. Because in areas where I've worked on TB, stigma affects sometimes the women very greatly, because they are under pressure that they cannot deliver in terms of cows for marriage and things like that. So maybe it has nothing to do with what you are discussing, please.
No, this is very important. Thank you. Actually, I had a slide, but then I had to reduce all the slides. This is very important area. And it's like there is a variation. When we looked at some countries, for some countries you can see the stigma among men more than women, because they fear that they will lose their jobs and they don't talk about it. Or in some countries it's more among women, so they don't talk about this one, even like among the family and others, or access, they don't have access to, so it's more like, go back to the 3 types of stigma. But there is a variation, but this is a good point and very important to highlight, whether when we design our interventions or any assessment, that to look at this issue. Thank you.
Excuse me.
Thank you for this really interesting presentation. My name is Brian from the United States. I was a little confused. So there's a lot of talk and investigation about TB stigma, the different forms it takes based off of Goffman and other writers and thinkers. And then there's a lot of evidence that there's comorbidity of mental health and TB. But I didn't see the link between those two discussions. So is it the case, are you saying that what you see is that TB stigma can lead to or exacerbate mental health? But that then, the other idea would be that there's some kind of compounded stigma that people face who have mental disorders and also TB, because of course mental disorders totally separate from TB are also stigmatized. So are there studies, or is that part of what you're looking at, is this kind of compound stigma, or is it just the relationship kind of directional between how stigma associated with TB may result in or exacerbate mental health disorders?
Yes. Thank you very much. So we looked at this specifically. There is one study that looked at this, exactly the TB and the stigma specifically, but also studying the mental health disorders. It seems like a cycle. Like you develop, like you have it, like the individuals, they have TB, then they develop eventually the mental, among them like 70%, 40 to 70%, they develop the depression or an anxiety, for example. Or they have the depression and an anxiety as Samson presented, but because of this, they don't seek treatment. If they have the infection, they don't eat well, they are more vulnerable to develop TB. So it's like a cycle, but there is no specific study. And this is also a very interesting area. One of the slides that I wanted to include but just try to focus on this. What are the key research areas that we need to focus on to address TB and stigma? One of them, in addition to this, one of them is to look at this problem, like whether it's mental health disorders or the TB. So there isn't much. There is, in the references, you can see tuberculosis and the stigma. They looked in general about the causes, about the challenges and the responses of the community, but not looking exactly at this aspect, which is, I think, very important. But the cycle that I think we presented is just to show it's like a cycle. Like if they have this, they can develop, or they are more vulnerable to have the other one.
Okay, just one quick question.
Yeah. Thanks. This is Bobby Ramakant from CNS. Thank you, doctor, for this presentation, and I'm glad that you mentioned self-stigma or shame or internalized stigma. I was just, like we have, at CNS we have interviewed several people with TB, MDR or XDR and other conditions for over the years, and we feel that probably we need to distinguish more between self-stigma and stigma out in the health setting or community, because self-stigma needs different kind of coping mechanisms, and there is hardly anything available on self-stigma. So did you come across anything, any toolkit to how programs can incorporate methods to deal with self-stigma? And second is on disability and caused because of tuberculosis, and that actually exacerbates the stigma. Like for example, people who develop deafness or profound deafness or blindness, for instance, and they get cured of TB, but they keep dealing with those disabilities for the rest of their lives. So and the TB program's responsibility is over after treatment is over. So where do they go? Like, how do they cope with that?
Yes. Thank you. Thank you very much. Yes. In the subcategories for stigma, it's good that you highlighted now and you distinguish between the anticipated stigma, the enacted stigma, as well as the perceived or anticipated. So most of the interventions and the programs and the studies focused on enacted stigma, which is the stigma that results from the inferiority. It's not the sense of inferiority, but results because of the inferiority and isolation, mainly the community, like looked at the community and their actions, their interventions, how they can help the patients, less on the self-stigma and the shame, how to deal with this, how to support the patients, TB patients, MDR TB. Less on that, but I do agree with you, we should have, and that's why when in our model, that we should have specific interventions or package of interventions that will specify set of interventions for the self stigma, as well as the stigma resulted from the inferiority at the community level. So in the cycle that we have, the self-stigma is after that you have the anticipated stigma or a fear from TB or having TB.
Thank you. Thanks, Dr. Hala. We'll have more time for discussion at the end of this session. All these questions raised here, these are all very important, very complex, and it's really very difficult to address all of them right now, and no one would have exact answers to those, because stigma is a very complex social phenomena, and in different settings, depending on the social status of men and women, it will have a different implications in terms of how cases are detected, how TB is managed, how mental health issues are addressed, and of course there are a lot of very important dimensions related to stigma mentioned here, so like self-stigma and also compounded stigma. In fact, TB-related stigma is not really well explored, and it's even more difficult when it refers to mental health and TB-related stigma together. And of course, we need to discuss more to come up with a specific set of interventions on how can health systems and national TB programs address both collectively to make sure that we achieve our end goal related to good treatment outcomes and good quality of life for patients with TB and maybe with coexisting mental conditions. Now it's my privilege to give the floor to Dr. Ignacio Monedero. Dr. Monedero has decades of clinical practice experience as MDR TB clinical practitioner. He works for the International Union for Tuberculosis and Lung Health. And today, Dr. Monedero will speak about clinical management aspects of TB and related mental health issues. So please, the floor is yours.
Okay, thank you very much. Can we have the presentation, please? Okay, thanks everyone. It's quite an interesting topic, but we only have 15 minutes, so I will try to speak not too fast, but good enough I'm sorry about my bad English, especially when I speak really fast. Okay, I have no conflicts of interest, and let's see what are the key challenges in TB. What makes TB a quite social disease? On one side, what we have is what makes patients clinically much more vulnerable. Usually when the immune system is reduced because of malnutrition, HIV, diabetes, or for example, children, all of these are going to be much more difficult to diagnose, and also the treatment is going to be much more complex. But on the other side, what we have is making socially much more vulnerable. Which are these kind of key selections? They are patients who usually are alcoholic or they have any kind of mental disease with social exclusion. Which are these kind of patients with social exclusion? Again, with drug abuse, homeless people, sex workers, or minority or migrants. But as you can see, most of these things, they are interacting one to each other, because if you are a minority, probably you are also with extreme poverty, and you have any kind of extreme poverty, you end up being a sex worker and getting HIV/AIDS. So it's not something that is just linear. It's really a web. It's like a net, completely interacting one to each other. So the point is, all of these cases who are socially much more vulnerable, mental disease plays a crucial role. Do you know do you ever see any alcoholic patients that don't believe that have a mental disease? Or do you see any kind of homeless or drug user that you don't believe that is mentally stable? Or do you believe that it's easy to be mentally stable when you are taking drugs for almost 2 years? It's not at all. In fact, what my patients usually tell me is that the line for the fault is really, really narrow. You need to be mentally stable to keep taking all these poisons for a couple of years. So all of these issues are linked to a reduced or a late care on access, of course, a loss to follow up. But as you can see here, all of these can create the other, and so there's not really in one direction. Clinically being more vulnerable creates you some kind of a stigma that it's going to create much more socially problems, and all the way around. And in the middle of everything, what we have is drug-resistant TB. Yeah, because all of these drug-resistant TB patients are the most vulnerable among the vulnerables. So drug-resistant TB especially thrive among those patients who are lost to follow-up defaulting, and also because if they have some kind of reduced immune status, they are just primary MDR. So all of this is coming together. So this is the outline of my presentation. I'm going to talk quite briefly about alcoholism, depression, anxiety, drug abuse, and also occupational TB, things that you are doing that puts you closer to be a TB patient. And again, I'm going to end up with some touches, not much about models of care. So alcoholism, the definition, of course, is a mental disease. The more that we know about alcoholism is that it's not really, it's something like diabetes. It's a genetic disease that is triggered by social or vital situations. So when we can consider that someone is alcoholic, when there is some problems with the family or in the working dimension or in the health dimension. Again, if you have problems in your social or working or family, you are going to be less likely to be adherent. Of course, family, the inner circle, are the ones that are going to push you to continue with the TB treatment. So they are going to be losing one of the big pillars. And again, if you are losing your job, you are going to be close to be in this kind of social exclusion because you get impoverished. And again, what is the health dimension? Comorbidities, much more difficult to make the management of TB. Of course, as you know, alcoholics, they used to have problems in the liver. And what about the medications? Most of the first-line medications are liver toxic, so we have to do things completely different. And at the same time, especially when they are drunk, alcoholics can be on a violent behavior. Violent behavior with a lack of esteem, self-esteem, and of course, the point is that nobody wants them in the world. So it's really, really difficult. They are outcasted even from the family, from family, not only from family, but also from the hospitals as well. So on the health dimensions, what we have is liver disease, again, alcoholic withdrawal and delirium treatments in the hospital. That is something that I don't recommend you to any one of you. No? Having a delirium tremens in the hospital is really, really a troublesome. They can be extraordinarily violent, and these people can definitely, they can die, or they can aspirate their own vomit and becoming with pneumonia. So the management of these TB cases is really, really difficult. And again, how to treat this kind of alcoholic withdrawal with anxiolytics, but at the same time, anxiolytics reducing the ventilatory system. So everything is playing against them. And again, most of these patients remember that alcohol is a sugar. Most of them, they don't feel hungry. They just drink, or they are just thinking about the next drink, but they are not thinking about taking organic food at all. No? So most of these patients have plenty of vitamin deficiency that at the same time is going to create much more second-line drug adverse reaction, for example, with INH or with linezolid. Yeah? So again, what is the problem with malnutrition? With malnutrition, especially with those patients that are with a big stomach but extraordinarily skinny, is that drugs are not absorbed. If drugs are not absorbed, drugs are where? Probably in the stools. If they are in the stools, they are not in blood. If drugs are not in the blood, you are not killing the bacilli. So everything is going to be much more complex with them. And again, typical hepatotoxic medications, pyrazinamide, INH, remember that both are also included in the short regimen. So the short regimen for MDR is also hepatotoxic. Yeah? Rifampicin, which is the cornerstone of the management, especially of the TB, HIV, and ethionamide, prothionamide. What other drugs can create problems, especially linezolid? As you know, linezolid is creating mitochondrial toxicity, and in these kind of cases, they are much more linked to heart, to develop some kind of underlying heart disease and also neurological conditions. And what about cycloserine? As you know, cycloserine goes very well into the blood-brain barrier. So whatever is the mental condition, its trigger, the threshold for developing any kind of mental conditions goes down. It can be seizures, it can be depression, it can be violent behavior, everything goes down. And of course, these kind of patients, alcoholic patients, they have plenty of other mental issues. Yeah? So what to treat? Usually what we treat is with liver-friendly medications, which are mainly with streptomycin, levofloxacin, ormoxicillin, ethambutol. And what about cycloserine? Cycloserine is liver-friendly, but if you have mental problems, again, it's something that playing against. Yeah? So the key point is that there is not too many information in international guidelines on what to do with alcoholic patients. Do you treat cases among you? Are you clinical physicians? Yes? No? Well, the point is that alcoholic TB patient is really our daily bread and butter. They are already there. Yeah, and whoever don't see this clearly is because the patients are not diagnosed. Probably the family is not going to tell you, okay, my father or my mother is already an alcoholic, but they are there. Yeah, sometimes you realize when it's already too late. Yeah, so there is no information on the new drugs. There is not even information in the international guidelines what to do. So this is one of these key gaps to see what to do. Yeah? And again, how to treat? Try with vitamins and also minerals, try malnutrition, and also you need to decrease the craving, the search of medication, the search of the next drug with anxiolytics. And again, what we have to achieve in the hospital is probably low-level consumption. And again, most of these patients have key problems with psychosocial support. They don't have the families, they don't have any kind of support, and we have to be there, because if they are not supported, they will be probably defaulting, right? So during the treatment, we need to close monitor the liver enzymes, yeah, and also try to check if the enzymes are going normal. Yeah? But the point, and I want to stress, is that nobody wants them in the ward. So sometimes the people is just happy because they are defaulting, and this is the reality. Yeah? So what about mental disease? Mental disease, as we mentioned during the stigma, goes in both ways. TB creates mental disease and suffering a lot, yeah? Of course, it creates a lot of depression and a lot of anxiety. And all the way around, mental disease is linked to tuberculosis, and also is linked to tuberculosis with resistance, whether there is evidence or not. If you are not adherent, you are going to end up with resistance, yeah? So this is why in the few studies available, bipolar disorder, borderline personalities of people with drug with drug dependence are much more linked to bad adherence, ending up with resistance at the end of the day. So what to do? What to do with mental disease from the clinical perspective? What we have to achieve is this: assure adherence. Why? Because someone that is suffering easily defaults, and our programs are not prepared for this. This is the kind of inconvenient truth that you are expecting to solve with pills and doctors, and that is definitely not enough. Pills and medications and doctors, we need a program to alleviate all the problems of the patient. Why? Because if we cure TB, probably it's going to be fine, but we need to cure TB, we need adherence. So it's like this kind of never-ending issue. So what to do? Try to alleviate all the problems of the patients with socioeconomic, including this: shelter, food, and social security. These kind of very, very basic things are working quite well. We need to be very aggressive with the management of side effects, and also we have to be effective on a spiritual and also in all the dimensions of the patients. And again, we need to treat all the mental diseases. Someone on the audience was asking what to do with these patients. Probably the first line, the physicians working with TB, we need to have access to anxiolytics, to antidepressant, and also the few capacities, because it's not really rocket science, diagnose anxiety or diagnose depression. We can make most of the things, yeah? So we probably need much more comprehensive teams. What about the interactions? There are plenty of interactions with anti-medications, psychiatric medications, and anti-TB medications. For example, again, anxiolytic and respiratory failure, haloperidol, which is one of the antipsychotic most frequently used, with QT prolongations. The good point is that most antidepressants, they are not having drug-drug interactions. On top of that, we use them to treat the side effects, so it's really good news, yeah? And again, in many countries, the big problem is that there is no access to diagnosis of mental health. Of course, these people are not included in the study, so they are becoming one of these gray literature. There's a big gap. No, we all the people working on the clinical sites and nurses and physicians, we know that some things are going wrong, but there's no paper there. And people say, okay, there is no paper, there's no problem. That's not like that. Probably these papers have to be built and written. Yeah? So again, there's no access to diagnose, and even if there is access to diagnose, there's no access to treat this kind of problems. So it's really, really an issue. I think everyone have seen this kind of picture. Well, it's the scream from Munch. Yeah, in fact, it's TB related and mental related. Why? Because Munch was losing his sister when she was 6 years old because of TB, and of course the other sister was with bipolar disorder. So this, that is the icon of desperation, is absolutely linked with TB and mental disease. What I meant to say is that on top of that, we are making the problem even worse. Why? Because most of, or some of our medications, they are creating side effects. In fact, so cycloserine, as we mentioned, decrease the threshold for any kind of conditions. If we don't adjust very well the dose per kg, we're going to be in trouble. In fact, I've been working in TB in drug-resistant TB for the previous 14 years, and I see almost every 2 years someone jumping out of the window. So this is reality. To me, cycloserine is probably the most dangerous medication, just because the people is killing themselves or they are in violent behavior. Some classical is the knife fight in the world, just because of banana, right? For very stupid things, very young people, isolated, and also on top of that, taking cycloserine. What to do? Provide an umbrella of pyridoxine. For every 250 milligrams of cycloserine, deliver 50 milligrams of pyridoxine, and of course, we need to take all the antidepressant and anxiolytics. And again, efavirenz is not an anti-TB medications, but it's the gold standard management for HIV, or the key drug for HIV on the TB and HIV patient. And again, efavirenz is not driving you crazy, but it's making you to feel like difficult or sound dreams, and also people get stressed, don't sleep very well, they feel like a little bit drunk, and again, creates much more loss to follow up. Yeah? What about drug users? In drug users, this is something quite common that we found in this kind of special hospitals where we have people with vulnerable situations. Of course, cocaine probably is not a problem if you have enough money. Yeah? The problem arises when money is lost, because cocaine is eating your family, is eating the money of your family, is eating your wife, you are going out and steal money, and then is when you get in trouble with cocaine. Of course, cocaine in the world, someone that is a drug dealer in the world, is really, really a nightmare, because people with cocaine become really violent as well. With heroin, again, there's a complete destruction of all the social abilities of the patient, just become thinking on the next shot. So it is a whole completely social destruction. And again, much more prone to HIV, and again, much more prone to develop TB. So all these things are playing together, one on and on. To me, for example, cannabis, it wasn't really a problem in my hospital. Why? Because they are much more happy, they are not violent anymore, they eat much better. So, well, probably I was looking to a different side when they were smoking marijuana, yeah? But of course, if the authorities were there, I was probably, okay, go and stop that. But for all the other drugs, including chemical party drugs, it's really, really complicated, yeah? Of course, in HIV, we have plenty of information what to do with HIV and drugs and mental disease. We have nothing on TB. Probably we are lacking this kind of evidence, and I urge whoever can do it, yeah, to go and write something as wonderful as this paper that was built for HIV. Yeah. So again, drug-drug interactions, the classical problem with rifampicin and methadone. As you know, rifampicin is the most potent inductor of the cytochrome P450. So it's reducing a lot the doses of methadone. So whenever you are using methadone, please take care and use and increase by 1/3 the dose of methadone. I think I'm going to go faster because I think I'm out of time. I'm okay with time? I'm okay? Yes? Okay, so again, this is like a dark humor joke with occupational TB. Of course, commercial sex workers, this is the way that they are earning their lives. Of course, most of these people, this is not the kind of thing that they were willing to be when they were younger or when they were kids. No? I've never heard my daughter saying, okay, I want to be a commercial sex worker. Why people is getting this? They are getting on that because they are on drugs. If they are on drugs and also they are commercial sex workers, they develop HIV and then TB. And again, prisoners, we have plenty of problems with prisoners. Why? They get, again, HIV, they get endocarditis, they get mental disorders, and of course TB and HIV. And homeless people, at least in my country, I come from Europe, yeah, they are usually migrants or even people with high level of education, but with a very intensive mental disease, with extreme poverty, living on the street. Of course, this is a tough job. Yeah, these people get TB quite easily. Yeah, and again, no one wants them in the world. Right? So if you are mistreated, if you go to take your medications or your pill and the healthcare workers are treating you badly, or you are rude with them, what are they going to do? They're going to run away and default. Yeah, so not treating these kind of populations means that we are not going to be ending TB, right? So which are the approaches, and with this I'm going to finish, the medical approaches with this. The point is that, believe it or not, and this kind of Confucius sentence, but we only cure those patients who take their medications. So we need to build systems that make or force the patient to take their medications and be as much supportive of them, right? Why? Because these kind of realities are difficult to be treated. Do you think that they are thinking about how to be adherent the next day? No. TB is just one of the many problems that these people have. So we have to be as much supportive. Yeah? So again, which options that we have? We have, for example, the nightmare in the tertiary hospital, the patients default, or the regular DOT, that they continue to default and probably dying, or probably one of the other options is new sanatorias in a way of patient-centered approach, thinking about which are the necessities of the patient, which are the needs of the patients, the preference of the patients, regarding not only medical, but also these social issues. If we just treat the medical, we are not going to get adherence. And if we just think about the social issues, we are not going to treat TB or cure TB. So we need to do both of them. So we need more different and more flexible approach, no? And the point is that we cannot cope with the classical hospital scheme. And again, the point is we need to treat TB, we need to treat mental disease, and we need new places that can be supportive, not only from the clinical point of view, but also from the social, especially here in these big cities. And finally, I'm going to end just with this, telling the same. This is our wonderful song from Sting that says, "Don't judge me. You could be me in another life and in another set of circumstances." And it's right. You know, probably I am here speaking with you because I had the opportunity to be educated and then the opportunity of doing a masterclass and so on. But not all the people have this kind of opportunities. Maybe someone with my same genes but in a different set of circumstances probably was there just thinking of the next shot. Yeah? So with this, for anyone, as I was running too fast, now I write this editorial a few weeks ago. It was presented in Public Health Actions, where there is a development of all these issues. So thank you very much. I'm sorry to be a little bit over the time.
Thanks a lot. Any questions or clarifications? Maybe we'll take one or two for the sake of time.
Thank you, Dr. Ignacio. The very important presentation again. Just wanted to say that all these issues are very real in our countries as well. I come from India. But most of the times the counselors are not equipped to deal with the counseling, the kind of counseling which is required to deal with alcoholism, for example, which are sitting in the DOT center. So, I just wanted your insights on that part.
So what you are asking me what to do? Well, that's the $1 million question. It depends so much in which is your country situation, your program situation, and not even your country, your municipalities. I think tomorrow, by the way, tomorrow I'm going to be talking about that. Yeah? So how to strengthen your system to open the eyes to these realities. Yeah? It depends. If you have just every once in a while an alcoholic, probably you don't need it. But if you have plenty of people that is alcoholic, that is outcasted from families, probably what you need to do, yeah, is achieve a low-level consumption, achieve a place where they can sit down for a while, where they have food, where they have shelter, consider starting TB regimen, yeah, with DOT, with treatment of depression, with treatment of anxiety, and then go for the next step that is probably try to achieve a way to escape from alcohol. Escape from alcohol is almost impossible, yeah, because it's in most of our society and it's so easy to get, so available. But what we can achieve is alcoholics that do not drink. But this is quite difficult. The point is that you need time, you need to spend money to do that. Yeah? If not, the point is that these people, they die, but they die after transmitting the disease to many others. But the point is that, of course, something have to be done. I don't have any magic bullet for you. I will present tomorrow what we do in Barcelona, right? But it's definitely something that have to be put on the table.
Thanks a lot. Actually, we need to move to the next presentation. Thank you again.
Okay, thank you very much. Okay. So the next. Hello. So the next presenter, I'm really honored to present my colleague that is co-chairing with me, that is Tamar Ganubia from URC, based in Georgia. She's an MDR, TB and health system strengthening senior technical advisor at University Research and Company. She's a health policy specialist with a background as family medicine practitioner with over 20 years experience in health system strengthening and public health. And in 2016, Dr. Gabunia was leading the USAID Georgia TB Prevention Project, and she continues work as a technical advisor for URC and USAID and Stop TB Partnership on the introduction of active drugs and safety monitoring for new drugs in high-burden countries. Thank you very much.
Thank you, Sangzaso. Okay, I'll be short. I think a lot of very important aspects of relationship between MDR, TB, and mental health issues and how these can be managed within the health system were really well covered by previous presenters at this session. What I want just to focus is more a programmatic side of it. Like how can we manage and how can we ensure that the national TB programs are well designed, they're adequately prepared first to recognize and then to respond to tuberculosis and mental health issues, which can be coexistent or they can be interrelated, like TB can lead to mental health issues, or there can be patients with pre-existing mental health conditions which we need to treat because of coexisting tuberculosis. So I have no conflict of interest to disclose in relation to this presentation. And as I've just said, I will mainly focus on programmatic aspects and what kind of interventions were tried within the USA TB Care 2 project in different countries to make sure that we are able to address TB and mental health related consequences. So here we'll know that a relationship between these two is bidirectional, and TB can lead to mental health issues. The same is true for mental health conditions. So people with mental health, they experience a lot of social challenges. This can this can also lead to developing TB or lead to poor treatment adherence and all that. So again, data about prevalence is there, but it's not like a very strong evidence, and different authors indicate that prevalence of mental health conditions among patients on TB treatment and MDR TB treatment is in between 35% to 70%. I've just decided to take the highest level because I think the problem is quite severe, and it's very important to make sure that we do not underestimate the problem and provide an adequate response to it. So what are major programmatic challenges? Actually, within TB programs, we are mainly focused on TB, and we do try to diagnose TB and then manage TB as a condition. So in the context of patient-centered care, it's not quite a right approach, because now we want to treat a person as a whole with all its related social, economic, biological, spiritual needs, and that's why, so just to focusing on TB problems only actually is not a way we may want to go, because there are a lot of other problems which come with TB, and which these problems all need to be addressed. So then the question is whether or not the TB programs are prepared to deal with additional clinical, social, psychological, or economic issues which come with that TB problem. And the answer to this question is that mostly TB programs alone cannot deal with a set of different challenges related to different aspects of patient's life, biological condition, clinical needs, etc. That's why it's very important to make sure that people who deal with patients with TB diagnosis are well prepared to detect concomitant or coexisting clinical conditions, and if they are not able to deal directly with those clinical conditions, there should be some linkages with other programs in healthcare system to make sure that these patients reach mental health services or other needed services in a timely manner, and they get needed treatment and support. Just to list, and this list is not like a big discovery, because we all know that health system experience difficulties in competencies of healthcare providers, and these competencies are not always adequate to provide a comprehensive patient management. I'm not talking about just giving a direct clinical care for TB or MDR TB problems, but look at this as a patient's needs and address all needs comprehensively, including psychological, social support, social inclusion, and as well as employment-related needs and opportunities. Big challenge and big gap in many health systems, it's a lack of community support systems, and of course many programs work to strengthen community systems and ensure that community resources are mobilized to quality social care, to quality clinical care, so community-based clinical care, as well as palliative care and bereavement support, which can also lead to an important mental health consequences. So this is a framework we're trying to use for addressing comprehensively patients' needs, so particularly MDR patients' needs, which may experience mental health problems during their treatment. And interventions includes, this is a kind of a standard set of interventions, and this includes guidelines, training, capacity building. Well, this is a standard set of interventions, but these are very basic. And without doing all these things, it's very difficult to achieve a desired level of performance and to expect that the system and healthcare providers will be able to recognize and to manage problems related to MDR TB and also to mental health consequences. Here I would like to emphasize just a few important interventions we pay particular attention to. That's a counseling. Counseling is a kind of a standard, practice, and we do want that every patient receives this service from a standard TB management program. But then when it comes to mental health issues, the question is that enough to have a general counseling from a TB specialist or a general practitioner or a community health worker, or we should think about more specialized counseling, like counseling delivered by a psychologist or a mental health specialist. In this case, issue is that not all health care programs or TB programs have easy access to this kind of specialized services, and this gap is a very important area for future work, and this gap needs to be covered in many health systems. Actually, this is an example from our work in Bangladesh when we've had a comprehensive counseling program introduced for MDR-TB patients, and patients had pre-admission counseling and post-admission counseling. This was more to prevent mental health related complications during TB treatment, and also detect on time if there is depression or anxiety, and then to make sure that people get appropriate treatment. So again, next example of our work in Bangladesh, it's social support, and many programs use social support as a way to prevent, again, mental health, a social burden of diseases, and somehow possibly have a positive influence on in terms of avoiding mental health consequences. And here another example is vocational training, where we try to have a vocational training program and to have some skills building for patients during MDR-TB treatment to make sure that they have some opportunity for social inclusion and employment when they are discharged from a hospital. So all these things, of course, are very good, but still more specific and targeted interventions are needed to make sure that we have a well-designed set of interventions to address mental health events which may occur during MDR-TB treatment. And this becomes particularly important when we start thinking and talking and doing and introducing new treatment schemes. And right now there is a lot of discussion on encouraging healthcare providers and national TB programs globally to use new TB drugs, bedaquiline, delamanid, and with the new drugs introduction, we do speak a lot and think a lot about having active drug safety monitoring. And in this system, it's very important to find the right place for mental health related adverse events and to have these events properly documented and then analyzed. So far, data on that is quite limited, and I was looking at one country data these days, and this data says that there were 2.7% of patients with mental health related adverse events in a bedaquiline treated cohort. So well, it's very important to make sure that we collect more and more, capture the problem and have better data on that. So what needs to be done actually in the future? Of course, standard interventions which are right now in place in many national health programs, including counseling, social support, providing employment opportunities, etc. These are all very important, but more needs to be done, and most importantly, we need to recognize that the national TB programs alone cannot deal with all needs MDR-TB patients experience during the treatment. And in the context of patient-centered care model, when we talk about shifting patient care towards community-based resources, and just now we've heard how difficult it is to keep patients with mental health conditions which may have difficult social behaviors, like patients using drugs or alcohol. No one wants them in hospital, and then what are alternative arrangements for them at a community level? So actually, these are quite important gaps which require further consideration and programmatic treatment. So it's very important to make sure that we have a set of interventions designed to address comprehensively all these issues and to have linkages established and strengthened between national TB programs and the rest of the health and social care systems to make sure that we do really can implement the patient-centered care model in many countries. Thanks for your attention, and this is briefly what I wanted to share with you.
Any questions? Please, there on the back.
Hello. Mani Chinmay from MSF in India. So we also have many counselors and everything, and from our experience we see that as time passes, the counselors turn into someone who just give health education. That's something that we have seen a lot. So can you explain from your experience in different settings, how did you try to overcome this, or is this the same situation everywhere?
It's true, this is what I wanted to emphasize actually during my speech. Mainly right now, our counselors in many countries, it means health education. And we do try to introduce some depression scale and anxiety scale to make sure that they do screen people and they are able to identify people with having a potential or suspected signs of mental health conditions, but of course that's not enough. For a comprehensive management of people with really serious mental health manifestation of different problems, it's very important. I think it's very important to switch to more specialized counseling. Of course, the basic would remain the basic or general counseling, health education and all that, but for more in-depth and maybe more effective response, I think it's important to think about having specialized counseling introduced within the national TB programs. I know one example from Turkmenistan, when with the Global Fund support, they now have a psychologist included as for a baseline assessment. Results of this intervention is not yet available, so it's very early to judge about its effectiveness, but I think it's very important to think about different models and to come up with a more effective solution to this. Thank you.
Please.
Hello, I'm Carlos Kankadze, Chemonix International, United States. My question is, basically these projects, TB projects, are quite often or mostly donor dependent, and do we have enough evidence to say that if we address mental health issues during the programming, so we can reduce burden of tuberculosis and come closer on eliminating of tuberculosis? I'm asking this because I myself served as a chief of party for the TB project. We didn't have this component because it was difficult. I didn't have in my job description in the project from donor, and other also. But do we have enough evidence, and can we sell this to donors?
Well, evidence is not enough, and the question is, do we really need to sell this to get buy-in from a donor side? Because I think from a donor side is kind of more or less well-recognized problem that we need to strengthen capacity of the National TB program to address this issue. But to me, actually, the gap is that we do not really work well and closely enough with the mental health programs, and in many countries the mental health and the TB programs still go vertical and they are not integrated. They are poorly integrated in the community systems and in the general healthcare system, and many countries they declare that the mental health is a priority for them, and the many country governments they declare that the tuberculosis is a priority for them, and when it comes to cross-management of those two, then there is a gap, because it's very difficult to find this linkage in between these two, and we still have the terrible TB treatment institutions for for people with mental health issues, and I think it's a very timely now to start more active discussion without having a very robust, hard evidence on that, because it's a kind of a common sense. The link is obvious, and this is a social issue, and so it's very sensitive issue from both sides. I think we can just simply go ahead and start advocacy, high-level advocacy on that to make sure that we have a better integration in between tuberculosis and mental health programs. So thank you.
Okay, more questions? No? So I would like to introduce to our next presenter, that is Dr. Abu Al Imran, that is an mHealth specialist with extensive experience of developing mHealth tools and applications for TB programs. He worked for TB Care 2, Bangladesh project as mHealth specialist and currently supports projects aimed at developing e-tools for community-based patient management and clinical monitoring and supervision. So thank you very much, Dr. Abu. Please, the audience is yours.
Good afternoon. Thank you. I'm going to talk about facilitation of regular patient interaction with SMS-based mHealth tools. This is basically experience from TB Care 2 project, the tool we used to send reports from GeneXpert labs to the referring labs. The objective was to expedite the process of this treatment initiation. So I have to go a little bit of background. National Tuberculosis Control Program (NTP) introduced GeneXpert to reduce diagnosis time in 2012 and replaced. They introduced GeneXpert so that the delay caused by lengthy diagnosis by DST and culture. But by introduction of GeneXpert, it became possible to diagnose a patient in 2 hours instead of 6 weeks. But there again a challenge to, the samples are received from peripheral labs, and it was not possible to deliver the results on the same day because it was dependent on delivery person or by postal service or courier. So, which was again a challenge to initiate treatment immediately. So to overcome that issue, to introduce a reduced treatment initiation and delay of patient diagnosis with XDR-TB, expert reporting was introduced, which has introduced for GeneXpert labs to send test reports as soon as the test result is available. Expert reporting is a web-based tool. It's an application which allows the lab workers to send the results immediately after the result is available. This result was sent to the referring lab as a SMS message, and also at the same time a notification was sent to the patient that the result is ready. This should come to the health center to consult with doctor. So this is a sample result. Like, it's not a real result. It's a demo result for the referring lab. And the objective I already mentioned, that to reduce treatment initiation delay in MDR-TB patients. And electronic documentation. Obviously, previously there was no electronic documentation of these results found from GeneXpert diagnosis. So this is a key elements of expert reporting. That's how it works. I think. So on the screen, as we can see, from GeneXpert machine we get result, and there are tablet computers provided to the labs. So they input the result through the tablet, and they get it to the central server, the central database. And if result goes to the referring lab, and a notification goes to the patient to collect the result. And also this result is accessible from anywhere, because since it's a web-based application. So this is a reporting dashboard based in expert labs. It's a web-based interface. This is the flow chart, how it works. Patient gives sample to the referral lab, transport sample by courier to the GeneXpert lab, and GeneXpert lab diagnostic testing of sample. Lab technologists enter GeneXpert diagnosis result in a web-based application on a tablet PC, and result report is sent by SMS to the referring lab, and the notification goes to the patient. So this is another diagram, how it works. The coverage by end of TB Care 2 project, we managed to cover 26 gene expert labs in Bangladesh. That was covered by expert reporting. And results, I mean, by introducing expert reporting, we managed to reduce the treatment initiation delay from up to 15 days to 0 day. Since the result was instantly sent to the referring lab by SMS message. So these are the advantages, benefits of using expert reporting. An efficient way of send gene expert test results from gene expert labs to the referral lab. In addition to the sending results, test data is saved in a central data server for data analysis and decision-making purposes. Simultaneously, this application sends test results to the referral labs and notification to the patients to collect results for nearest lab. This way, it ensures to reach the test result to the patient at the same day of the test has been done. The application enables the newly diagnosed TB patients to get enrolled to the TB treatment on the same day of detection. This is obviously a cost-effective way of transportation of reports and reduce burden of human resource. So, of course, like all other interventions, it has some challenges. Initially, we experienced few challenges, which is some lab workers are really inexperienced to operate PC or tablet PC. And in Bangladesh, now the network coverage is really good because we have a 4G network. But initially, we had a poor network coverage. So that was a big challenge for us. Some labs had a big issue of sending results. So thank you. If you have any question.
Thanks a lot for a very interesting presentation. Questions?
Hi, Amanda Meyer, Yale School of Public Health. I just had a question about the patient receipt of text messages. We've conducted a study in Uganda that showed that only about 50% of participants actually received SMS messages that we sent to them. Did you do any sort of analysis to verify that patients were actually receiving the test results, or not the test results, the request to go to the labs?
Yes, that's a good question. Yeah, that in our expert reporting application, the SMS was really delivered to the patient's mobile phone number. But yes, there is a challenge. Of course, I mean, it's a very valid question. In our country context, sometimes a woman doesn't have a mobile phone. She doesn't have a mobile phone. Probably the head of the family has a mobile phone. So sometimes the message may not have been conveyed to the patient. That was a challenge. And also due to, letter of literacy is really low. So they didn't have a way to understand that what the message says, what message we are trying to convey to them. So these are this type of challenges we experienced, but we ensured that all not results actually, the notifications were delivered to the patient's mobile number. Yes, thank you.
More questions? Okay, thank you. With this, I would like to thank all of you for participation and for your patience and for staying here. We were over time, and actually the magnitude of the problem is huge, and we all know that evidence is enough to conclude that mental health can contribute to a significant portion of loss to follow-up in patients on MDR-TB treatment. That's why it's very important to be very aggressive in addressing this challenge and to think innovative and use new approaches to detection and management of both TB and MDR-TB in the context of patient-centered care. Thanks again.
Thank you very much, everyone, for coming. Thanks.
came. I did it. I made it. Hello, Trump. Yeah.
That's why, but I didn't know. I said, oh, there's an American lady. I thought, who will that be? In our case, it was 6. So they have to just adjust it. Yeah. Which guy is that? I guess the guy at that. So not only translating, facilitating. Bueno. Entonces estás pidiendo que yo pida a la señora y otra vez. I need to learn, but. So how do you want the translation happening? Yeah, but I mean, I'm not guilty about the fact that they put someone with no. To be honest, I find it ridiculous to do that picture if it's only English. I thought it was a mixture. Well, yeah. I'm not going to translate every session. Entonces, el problema es que todas las sesiones están en inglés. Entonces, ¿cómo tú ves tu rol? Porque yo no soy suficiente fluido para estar traduciendo todo lo que se habla inmediatamente, ¿sabes? Y yo no sé cómo hicieron un chair de una sesión que no tiene ni una presentación en español. intermediario aquí. El problema es, bueno, Darcy también no organizó esto, ¿no? Es la unión que te pone en esa posición de chair, mientras no hay nadie que va a hacer la presentación. Entonces, la funcionalidad de tener un chair que habla principalmente español es un poco cero. Entonces, ella se siente como un poco incómoda, que no sabe cómo decirte, pero en realidad lo puedes mejor hacer sola. Y tú, claro que puedes hacer preguntas, pero lo puedes hacer con público también, pero para dirigir al público va a ser prácticamente imposible, porque todo el mundo ahí son ingleses. Entonces, Manuel, si yo fuera tú, adelante, Darcy. Yo me siento allá en el salón y imagino que te gusta el tema, ¿no? Te quedas ahí sentado, puedes sentar al lado tuyo, nos sentamos allí, pero que aquí no voy a sentar. Me parece absurdo estar ahí detrás de ustedes. Nos podemos sentar en el público, sacamos esto simplemente y si tienes alguna pregunta sobre lo que quisieras ser esclarecido para ti mismo, te puede ayudar. Pero como chair no va a ser prácticamente imposible de hacerlo y te digo, a Darcy es una excelente chair, la conozco muy bien, estamos en la misma casa en realidad y por eso yo ni sabía que estaba contigo, pero no te está ocurriendo, pero está un poco como, ¿cómo hacemos esto? Cuando no hay, ¿qué te parece? Bueno, tú te quedas ahí entonces. Okay, so he prefers to stay, sit there and you did everything, and just for the interview. Yeah. No, not anymore. But he is important here because he's the head of health promotion now. No? So, promoción de salud estás, no? So he's in the state of Jalisco, they transfer, but he knows everything about TB because he did that for so many years. Yeah. And now, 15. And now he is the head of health promotion of the same state of Jalisco. That was done because, that's the government. They just put people where they are needed, not what they feel. But he still loves to be in this way. Just no me necesitas. And he can give in his own words in Spanish. Welcome. But I'm afraid there is nobody who understands him. Maybe.
So you advance the slide. Right. She will talk, and then you will do the translation. It's fine. And you don't have to go too fast because
We will try. She's very nervous. So.
yeah.
Yeah. Relax.
Hello? Can you hear me? Okay, good. We're going to get started because we have a lot of presentations to get through. My name is Darcy Richardson. I'm from the United States. I'm a tuberculosis consultant, and right now I work with USAID on a project to create a comprehensive framework for patient-centered care for people with MDR-TB. And it's my pleasure to welcome you to this session on psychosocial support, the impact on health-seeking behavior and treatment outcomes. I think we have quite a few interesting presentations today. And I also want to introduce my co-chair, Dr. Manuel Sandoval, who is from the state of Jalisco here in Mexico, the state that we're in right now. For 15 years, he served as the TB program manager here in the state, and TB is very near and dear to his heart, and he is now the head of health promotion in the state. Would you like to say a few words?
Welcome to Guadalajara, the beautiful city of Mexico. Welcome.
So unfortunately, we have no translation in this room, and Manuel is a Spanish speaker, so I will be doing a lot of the introductions for our speakers. Unfortunately, our first speaker from Nepal could not make it. She did not get a visa in time to the conference, so I'm sorry to say that Sudeepa Kanal will not be here. But I am very pleased to introduce our first speaker, Elena Tarasova, who is the chief nurse at the Tyumen Regional TB Dispensary, which is one of the largest healthcare institutions in her region. She's an active member of the Russian TB Nursing Network and winner of the ICN Leading Lights title for 2016. She has been involved in nursing research and will be presenting the results of her research project dedicated to psychosocial support for chronic TB patients on long-term hospital treatment. So please welcome to the stage. Elena will be speaking in Russian, and she will have a translator to help her with this presentation.
Здравствуйте, уважаемые коллеги. Я хотела выразить огромные слова благодарности за участие в этой конференции и предоставленную возможность поделиться опытом нашей работы.
Good afternoon, dear colleagues. I would like, first of all, to thank you for the opportunity to be here and for the chance to share the results of my work with you.
Тема моего доклада – оценка вмешательства медицинских сестер для улучшения качества жизни хронических больных, находящихся на длительном стационарном лечении.
The topic of my presentation today is evaluating a nursing intervention to improve the quality of life of chronic MDR and XDR-TB patients hospitalized for a long time.
За последние годы...
Sorry?
Okay. За последние годы заболеваемость туберкулезом значительно снизилась, но несмотря на снижение заболеваемости, увеличилось количество лиц с множественной лекарственной устойчивостью.
Well, in the last years, the TB incidence rates in our region have been decreasing. However, the MDR-TB rates have been steadily rising.
В одном из наших филиалов с 2014 года открыто отделение для лечения больных с хроническими формами туберкулеза.
In 2014, we opened a palliative care ward at one of our TB hospitals to treat chronic TB patients, that is, the patients who are suffering from largely incurable forms of TB.
Медицинские сестры этого филиала проводили данное исследование.
And we did a small study conducted by the nurses of this ward.
В исследовании приняли участие 50 пациентов.
50 patients were enrolled into the study.
Медицинские сестры проводили анкетирование с применением опросника SF-36.
Our nurses did interviews with the patients and used the SF-36 survey tool for this.
В начале исследования показатель физического благополучия у пациентов составил 40% у мужчин и 42% у женщин.
At the beginning of our study, the baseline physical component of the quality of life rate was 40% for male patients and 42% for female patients.
А показатель психологического благополучия составил 42% у мужчин и 51% у женщин.
The baseline mental component was 42% and 51% respectively.
Пациенты длительное время находятся на лечении вне семьи, оторваны от социума.
Our patients stay at hospital for a long time. That means they are disconnected from their families, they are disconnected from their normal environment.
Большая часть пациентов отметили... Большая часть пациентов отметили, что после постановки диагноза туберкулез отношение к ним близких изменилось.
And most of our patients reported that when they received their TB diagnosis, the attitudes of their relatives, of their families, changed.
Медицинские сестры разработали программу мероприятий, которая включает в себя.
So our nurses have developed an intervention, a patient support program, which consisted of several components.
Мы помогаем восстановить разорванные семейные связи.
First of all, we try to help our patients restore the broken family ties.
По возможности связываемся с семьями по телефону.
And whenever possible, we try to contact their families by phone.
Обучаем наших пациентов и членов их семей основам инфекционной безопасности.
Another component of our program is teaching family members the basics of infection control, so they would have no fear when they are when they're in touch with the patients, to be patients.
Мы открыли молитвенную комнату.
Another thing we did, we opened a prayer room for patients.
И дали возможность нашим пациентам напрямую общаться со священнослужителями.
And we gave our patients an opportunity to be in direct contact with their spiritual helpers, with the priests.
Предоставили пациентам настольные игры.
Besides, we provided our patients with leisure activities.
Пациенты имеют возможность рисовать.
Our patients have a chance to be engaged in hobbies, for example, painting.
Пациенты сами сделали цветники, ухаживают за цветами.
So our patients did do some gardening, do flower beds.
Таким образом, у них есть шанс проявить себя в чем-то и использовать свое свободное время для хобби.
So in this way, they have a chance to take their minds off their disease, and so these hobbies help them to suffer less.
И в целом это помогает отвлечься от болезни, от страданий.
So they're not thinking about their suffering and about their disease all the time.
После 6 месяцев лечения и использования применения данной программы,
after the first 6 months of our intervention of this patient support program,
показатель физического благополучия увеличился на 6% у мужчин и на 7% у женщин.
The quality of life component has improved, and сколько там процентов? Еще раз скажи. Has improved and was 6% more in male patients and 7% higher in female patients.
а показатель психологического благополучия увеличился на 12% у всех.
The mental component of the quality of life rate increased by 12% for male and female patients.
6% восстановили родственные связи и имеют возможность общения с семьей.
6 of our patients have reconnected with their patients, with their families, and have a chance to spend more time with them now.
Таким образом, подводя итог данной работы, можно отметить.
So, in conclusion, I would like to say the following.
Эти данные позволили выявить и оценить факторы, способствующие снижению показателей качества жизни.
So the data we received during our study allowed us to identify and evaluate the factors contributing to the quality of life rates
Для пациентов, находящихся на длительном стационарном лечении.
for patients on long-term hospital treatment.
Вмешательство медицинских сестер позволило нам не только улучшить показатели качества жизни,
So this nursing intervention allowed us not only to improve the quality of life rates for our patients,
но и укрепить доверительные отношения между медицинскими сестрами и пациентами,
but also allowed us to build more trust between the nurses and the patients
и восстановить родственные связи.
and restore the family ties for our patients.
Эти данные о пациентах в дальнейшем будут использоваться в других филиалах нашего учреждения.
So the data we received will be used in other wards. We are planning to use them to improve the lives of our patients in other wards of our hospital.
С целью улучшения лечения туберкулеза и оценки его эффективности.
And that will be helping us to make TB care more effective. Thank you for your attention.
Thank you very much. Does anybody have a quick question that they'd like to ask? We have time for maybe one question before we move on to the next speaker.
Прежде чем мы перейдем к следующему докладу.
Yes, please.
Большое спасибо, очень замечательный доклад. I cannot hear you, sorry.
Thanks. I thought that was wonderful, looking at how to improve the quality of life in patients who are in incredibly difficult circumstances. My question is, and you have to forgive me because I'm not really familiar with this area, but you don't hear a lot about anyone including a spiritual component at most medical meetings. So is this something that how did you decide to put this in, and where did that come from, and are a lot of people doing this?
Молитвенной комнаты и связи со священниками, потому что редко мы слышим о том, что заботятся медсестры о духовном, душевном состоянии больных таким способом. Как вы пришли к такой мысли?
Мы с пациентами проводили беседы, когда проводили исследования.
Thing is, when we interviewed our patients before we started our intervention,
И они как раз и навели нас на это.
our patients themselves ask us to take care of this area of their lives. So that's how we got the idea.
Okay, thank you, Dr. Corey from Nigeria. Apart from the reconnecting the patient to the families and the spare activities, what other care did you give to the patients?
Sorry, can you say it again? What are they? What?
Okay, so what other care did you give to the patient? Was it only the two, reconnecting back to the family and the spare time activities that used to measure the quality of life? I don't know.
Но на тот момент, когда мы проводили исследования, именно вот в этих факторах они нуждались, и они наиболее.
Well, thing is, when we started thinking about what we can do to help our patients on a long-term hospital treatment,
наиболее стояли ценными, наверное, на первом месте все же.
So that's what we considered a priority, this reconnecting them with the families, etc. Of course, they they did get other kinds of care, but that's what we consider the priority at the moment because that alleviated their suffering most.
Thank you so much for your presentation. And I think thank you also for highlighting the importance of getting patient input in your interventions and for showing that you can do a lot with very little money. All right, thank you. Okay, it is my pleasure to introduce Dr. Annette Trashman, who will talk today about the impact of the Brazilian family health strategy and the conditional cash transfer on tuberculosis treatment outcomes in Rio de Janeiro. And Dr. Trashman is a Brazilian physician and professor of medicine who's worked on TB operational research for the last 20 years. And she focuses mostly on pragmatic studies on latent TB infection treatment and new diagnostic tests for TB. Thank you very much.
Thank you. So I'm going to talk about these two federal government programs in Brazil, the Family Health Strategy and the Cash Transfer Program, which is called in Brazil the Bolsa Família. Let me talk a little bit about the context first. Brazil has the largest public health system in the world. 140 million persons rely exclusively on this health system. We are one of the high TB high burden countries. We have 70,000 new cases yearly. Rio de Janeiro is the third city with the third highest incidence rate, 90 per 100,000 per year. And I'm going to talk about these two programs. So the Family Health Strategy was created by the federal government in '94. It has been expanding in the country since then, and in Rio de Janeiro, it has expanded a lot in the last decade, and now it covers 70% of the population. But it was a progressive expansion. Each family health team has one physician, one nurse, and 4 to 12 community health agents. Those are people who live in the community and go in the community to do home visits. They are not health care professionals. They have minimal training, but they are people who are very close to the community. And each family health team is responsible for 1,000 families in the area around the clinic. So they are responsible for between 3,000 and 4,500 people. And the idea is to have a patient-centered, integral, and continuous health promotion, prevention, and assistance. The conditional cash transfer was derived from previous social protection programs in the country. It currently covers 12 million families in need. The program has educational conditionalities and health conditionalities that are followed by the family health clinics. Both programs have beneficial effects on health outcomes in ecological studies. So until now, only ecological studies have been done to analyze the impact of the family health strategy. One study, one systematic review done by one of my students showed that the higher the family health strategy implementation, the lower the infant mortality, and it has also less clear effects on other health outcomes. And a few studies have also shown improved specific health outcomes, including the TB incidence. This is a very recent study in Brazil. But there is always the risk for the ecological bias, which means that you are not, the unit of analysis is, in this case, the municipality. So you don't really know if people who are have the outcome are the people who are under the exposure. We have one individual study showing the benefit from the cash transfer in TB outcomes. This was done in last year, and it showed that there was a 5% gain in the outcome for cure rates or treatment completion. So we wanted to estimate the effect of the family health strategy and also the synergistic effect from the cash transfer program on TB treatment outcomes using individual patient data. So this was a huge work. We had to link 3 databases: the Family Health Strategy Registry, the cash transfer payrolls, and the TB notification system. We only included patients over 15 years under the standard regimen for TB. The study covered from 2011 to 2014 because we had high quality information from this period. And we stratified our analysis by new and retreatment cases. So our outcome was successful treatment, either cure or treatment completed. The exposure was family health strategy. And I think it's very important to say that the comparison is not nothing. So people who are not covered by the family health strategy, they are covered by the traditional clinics, primary care clinics that are in the country for ages. Okay, so it's not primary care versus nothing. It's family health strategy versus traditional models of primary care. And we adjusted our results for sex, age, race, schooling as a proxy for socioeconomic status. We didn't have income information, site of TB, HIV, diabetes, and drinking habits. And we first did an analysis with all patients. We did not find any effect of the cash transfer program. We found this very strange compared to the results in the national database, the study I have shown to you before. So we looked at the stratum of people with low education levels, so those under 4 years of schooling. And we looked at the independent effects and the synergistic effects and the interaction. So what we found is that the family health, people who were covered by the family health strategy had a 14% higher chance to be cured, well, to have treatment success. From 73% to 83%, this is a huge gain. Among retreatment cases, this gain was from 51% to 71.6%, adjusted for other variables. This is a 35% increase. Among those under 4 years of schooling, the cash transfer increased by 19% the chances of successful treatment, and the family health strategy by 20%. Those who had both coverage had a 55% increase. There was no interaction and no synergistic effect among the two. Not with the methods we used in this sample, which was not very big. And for the retreatment cases, the cash transfer had a 53% increase. The family health strategy, a 46% increase, and those who were covered by both had a 41% increase. Again, no interaction. This was not statistically significant. We had only 385 people in this category. So our conclusions are that there is an important effect of the family health strategy as a model of comprehensive care. We don't know, this kind of study does not allow us to say what in the family health strategy worked. Is it the health conditionalities? Is it the home visits? Is it the closeness of the clinic to the area where they live? Is it the integral and continuous care? This is what I believe that works. We don't know. We know that the package worked. There is a clear and independent benefit from the cash transfer as well. And universal health coverage, integral health care, social protection, and intersectorial approaches are needed to tackle the TB epidemic. I think that we need much more than simply giving medicine to people. Thank you very much.
Hello, thank you. Thank you very much for that wonderful presentation. I think it raises a lot of interesting issues. I'm sure we can have a robust discussion about your data. And in the interest of time, because this is an oral abstract presentation, I'm going to try to move through the presentations quickly, so please remember your questions. And when we have all the speakers finished, then we'll come back and have some time for discussion. So thank you very much. All right, it's my pleasure to introduce Dr. Chen Guoji, who is coming to us from China. He has worked as a TB clinician at the Wuhan Pulmonary Hospital and Wuhan Institute for Tuberculosis Control in Hubei Province, China, for the past 8 years. And it is the largest city in central China with a population of about 10 million people. And he is going to talk today about the impact of hospitalization subsidies on TB treatment outcomes. Thank you very much. Please.
Mr. Chairman, ladies and gentlemen, good afternoon. I am honored to be and proud to have the opportunity to speak at this meeting. My name is Chen Guoxi. I come from Wuhan City, China. As we know, China has the third largest burden of TB in the world. Also, China has achieved a high treatment success rate since 1995, but still faces significant challenges. Completion of TB treatment is a major goal of any public health program. Non-adherent patients are more likely to fail treatment, develop drug resistance, take a longer time to convert their bacteriological status, transmit the disease, and relapse. TB patients with any type of incentives are more likely to complete treatment than those without incentives. We have made some attempts to improve patient adherence. Today, I would like to share our experience. In China, the free treatment policy covered the cost of the whole course of the first-line anti-TB drugs and basic examinations, including sperm smear and culture, chest X-ray, and blood files for liver function. All patients need to pay their hour medical costs before TB diagnosis. In fact, these costs are mostly caused during hospitalization and represent the majority of the medical costs related to TB service. Financial costs were still found to be the most cited reason for TB treatment default. Use of financial incentives have proved to be beneficial in TB treatment completion among vulnerable populations such as prisoners, homeless populations, and drug users. However, most of the experience has been limited to the prophylactic treatment of latent TB. In Wuhan, all TB patients, including suspended TB patients, must be referred to the designated hospital for the diagnosis and the treatment, but not forcibly hospitalized, and then return to the community health center to receive treatment supervision and follow-up, not stored. In order to reduce the transmission of the disease, encourage the patients to hospital for treatment. Since 2012, Wuhan local government has implemented an incentive project in designated area. Those patients who were adherent to TB patients treatments were given hospitalization subsidy to incentive them to successfully complete treatment. In the project, if the patient met the criteria, they were interviewed by a TB medical worker and have to sign a letter of undertaking to signify that they understood the purpose of the project. Patients have to pay the hospital costs upfront, keep the receipt, and reimbursed self-paid hospital costs at the end of their intense phase and the whole treatment respectively. In our study, there were 115 and 110 TB patients registered in the intervention and the control group respectively. Data pertaining to patient demographics and the treatment outcome were obtained from the medical code questionnaire and the clinical attendance form. No significant difference was found in gender, age, marriage status, employment status, education, and insurance status between the two groups. Nearly 20% of the TB patients are from the low-income family. Half of all patients advised TB had a certain effect on family economy. And our average subsidy is almost 2,000 RMB. The range time of the hospital stay of the intervention group was longer than that of the control group. Oh, sorry. Oh, okay. We compared treatment completion rate. In intervention group is 89.5%, higher than the control group, 77.3%. A total of 6 patients defaulted in the intervention group, lower than the control group, with 17 defaulting in the same period. We also look at the adherence in the follow-up period. There are missed appointments in both groups during follow-up. There are 15 patients missed appointment in the intervention group, which is better than that of 26 missed in control group. The missed of the one time and above one time in intervention group are less than that of the control group. Kaplan-Meier survival curve analysis show that intervention group show missed appointment was later, as shown in the figure. Most of the patients in both groups reported there's no missed dose in whole treatments, but the intervention group Morisky score was generally lower than those in the control group. The stratified analysis in missed appointment and medication adherence are similar. Young patients, non-material status, alcoholism, and drug abuse are the high risk factor. Discussion. There is a study reports financial incentives may be more effective than non-cash incentive in improving treatment adherence, but it is controversial. In our study, the financial incentives provided to patients account for a significant proportion of their medical cost. The cost of subsidy is higher than other studies. Most of the patients in the scheme informed us that the incentives were beneficial and a good motivator for them to follow through with the treatment. The incentives working was a performance reward. Patients reward money after they have completed the course of treatment. So whether rewarding cash using on other purpose may inadvertently affect the treatment result. The results show that the intervention group have a more knowledge of the disease and have a better medical adherence because these patients have more hospitalized time to accept health education and more communication with doctors and health workers. We think this is also the factor that improves the adherence. And in the percent of the young TB patients are more than the older patients. The most cited reason is work. Cultural factors are also associated with the medical aspect of TB and stigmatization of patients with TB. Married patients' adherence is better than the single patient. And the alcoholism patients and the drug user patient did not complete the treatment. So no financial incentives cannot improve these patients' adherence. This project was designed to be embedded in existing TB servers. That is, no actual step time was required in TB clinics. And our study have some limitation. First, the study was limited to the central urban area of Wuhan city without rural areas, which cannot statistically expand the general population of all patients. Second, the patient was a retrospective study. They are less reliable than control obtained from randomized control child. The non-adherent patient was directly asked for their reasons, as much they may not have been forthcoming about the real reason. Finally, I would like to make a conclusion with this presentation. Financial incentives to be effective in improving treatment completion, duration, and successful rates among TB patients. Okay, thank you. Thank you very much for your attention.
Thank you very much. We have, since you finished a little bit early, we have time for one quick question if anyone has a question from the audience. Any questions? I just want to say that I think your presentation really highlights the very serious impact that financial burden has on patients in China in particular. And so we have very many different situations when we're looking at financial and social support for patients. And certainly in China, providing that financial incentive really helps them be able to complete treatment. Yes. Thank you very much. Okay, our next speaker is Faye Stevens. Faye holds an MPH in Global Epidemiology from Emory University's Rollins School of Public Health. She now works as an epidemiologist for the Georgia Department of Public Health in the HIV/AIDS Epidemiology Surveillance Section in Atlanta, Georgia, in the U.S. And she's passionate about contributing to evidence-based decisions that improve health outcomes for marginalized populations. And Faye will be talking about treatment adherence among persons receiving concurrent MDR-TB and HIV treatment in KwaZulu-Natal.
Thank you. Good afternoon. Thank you for the opportunity to present today. I'm going to start with a little bit of background. Multidrug resistant tuberculosis is defined as infection with TB bacteria that is resistant to at least 2 of the most potent first-line anti-TB drugs. With a global treatment success rate of between 50 and 60%, it poses a complex and critical public health problem in communities across the world. Among people living with HIV, TB is the leading cause of mortality. And when co-infection occurs in the context of drug-resistant tuberculosis, the consequences are amplified markedly. South Africa is experiencing a convergence of these epidemics in recent years. It is estimated that there are approximately 15,000 new cases of MDR-TB in the country annually, with a 70 to 80% HIV co-infection rate. The World Health Organization recommends co-treatment of MDR-TB and HIV for all co-infected patients. Adherence to treatment is critical to successfully treat both drug-resistant TB and HIV. However, it can be very difficult for patients to maintain. Treatment for drug-resistant TB is long, lasting at least 2 years, and complex, with a high pill burden, overlapping drug toxicities, and the potential for severe adverse events. Directly observed therapy has historically been the recommended method for ensuring full treatment adherence and treatment success in treating TB. However, in practice, resources are often limited, and DOT is not always feasible to implement fully. As an example, in South Africa, the actual DOT coverage is often much lower than the standardly reported 100% level. This has left several critical gaps in knowledge. First, regarding adherence to drug-resistant TB treatment, and second, regarding adherence to drug-resistant TB and HIV treatment in co-infected patients, which in this context, there are amplified consequences of poor adherence, which could result in compromised outcomes for both diseases. As a result, in a cohort of persons with MDR-TB, we sought to first compare full adherence to TB treatment among a cohort of people with and without HIV infection. And second, to investigate differential adherence to antiretroviral therapy and TB treatment among co-infected patients. And finally, to investigate the association of TB treatment adherence with TB treatment outcome. We did this through the SHOUT MDR study, which is an observational prospective cohort of 200 MDR-TB patients who were enrolled from 3 different treatment sites in KwaZulu-Natal, South Africa. 144 of the 200 enrolled participants were HIV positive at baseline. We followed participants through 2 years of monthly study visits. All received standardized MDR-TB treatment, and all HIV-infected participants received antiretroviral therapy. We collected HIV and TB medication adherence measures separately at each monthly study visit. And at each visit, 3 individual adherence measures were collected. The first 2 are recall questionnaires, which ask patients to report any missed medication over the last 3 and 30-day periods. And the third is a visual analog scale, which is the picture below, on which participants were asked to report their percent or their proportion of adherence to their medication in the last 30 days. We then created a composite adherence measure, which indicates full adherence or no reported missed medication according to both the 3-day questionnaire and the visual analog scale. And for our analysis, we defined full reported adherence as no missed medication at any point in the study. This binary measure was measured by each of the 3 individual and the composite measure. Finally, we defined 2 primary outcomes for TB treatment. The first is overall treatment success, which I dichotomized into either success or failure. And the second was 60-day TB culture conversion, defined as 2 consecutive negative TB cultures within 60 days of initiating treatment. We first assessed full adherence to TB treatment in our overall study cohort and then compared to persons with and without HIV co-infection. Next, we assessed full adherence to antiretroviral therapy and compared it to full adherence with TB treatment among all of our co-infected participants. And finally, we assessed the association of TB treatment adherence with TB treatment outcomes using the composite measure to indicate adherence. We used log binomial regression to produce risk ratios for our 2 TB treatment outcomes. Shown here are the characteristics of our cohort at baseline. And I know this is a lot of information, but the main point is that our HIV positive and negative cohorts were fairly well matched at baseline with a few exceptions. First, the HIV positive cohort was slightly older, and they were more likely to be female and to have undergone previous TB treatment. Additionally, at baseline, approximately 80% of our HIV positive participants were on antiretroviral therapy. Displayed here is our primary outcome of full reported adherence to TB treatment among the full cohort and stratified by HIV status. We calculated the proportion of participants who reported full adherence to TB treatment according to each of the 3 individual and the 1 composite measure. As you can see in the top row, full reported adherence to TB treatment in the study cohort was high, above 80% by all measures. Similarly, adherence was high among the HIV negative and positive cohorts. As an example, if you compare the top to bottom rows for HIV positive versus negative, according to the first measure, the 3-day recall, 84% of patients with HIV reported full TB treatment adherence, compared to 88% of HIV negative participants. This trend was similar across each of our adherence measures. And this indicated that adherence to TB treatment did not differ significantly by HIV status, despite the increased pill burden and treatment challenges. Here we display our comparison of full adherence to antiretroviral therapy with adherence to TB treatment among co-infected participants. As you can see, antiretroviral therapy adherence, which is displayed by the dark blue bars, was significantly higher than adherence to TB treatment, which is displayed by the light blue bars, according to all 3 individual and the composite study measure. And finally, displayed here is our association between treatment adherence to TB treatment and our 2 outcomes. We use the composite measure for adherence here. Displayed on your left is the crude and adjusted likelihood of TB treatment success among participants who reported full TB treatment adherence, compared to those who reported less than full adherence. And similarly, displayed on the right is the crude and adjusted likelihood of 60-day culture conversion among fully adherent participants. We found that the likelihood of a positive treatment outcome, either treatment success or culture conversion, was higher among participants who reported full adherence to TB treatment. In our analysis, however, these comparisons were not statistically significant. Our study did have several limitations, the first of which is that reported adherence in our study population was really high, which limited the number of participants in our non-adherent group and therefore our power for comparison. In addition, recall bias and social desirability bias may have impacted our self-reported adherence measures, which may have caused us to overestimate the level of full adherence in the population. And finally, the lack of objective adherence measures available in the study limited our ability to detect all truly non-adherent patients with more confidence. However, we are currently undergoing further analysis of pill count data and clinic visit adherence in this effort to find a more objective adherence measure. Despite these limitations, our findings lead to several conclusions with important public health impacts. First, we found that co-treatment of MDR-TB and HIV can be administered successfully while maintaining high treatment adherence and treatment success rates. Additionally, it's critically important to identify more objective adherence measures, especially in the context of drug-resistant tuberculosis, not only to accurately identify non-adherent participants, but also to target and support interventions to these persons. And finally, it's important to investigate that preferential adherence to antiretroviral therapy that we found in order to learn and apply key lessons from HIV treatment programs to improve adherence to TB treatment. This finding is supported by qualitative evidence, which suggests that there is more support, patient education and empowerment, and less stigma in HIV treatment programs that may be applied to TB treatment programs. Taking these steps will not only improve outcomes for individuals with MDR-TB, but it will also limit transmission and further resistance in families and communities that have been affected by this devastating epidemic. I'd like to thank the entire Emory Einstein CDC research team and the staff at the University of KwaZulu-Natal, the KwaZulu-Natal Department of Public Health, all of our participants and their families and the providers that made the study possible, and last but not least, our generous funders who made the study possible. Thank you for your time, and I welcome any questions you have.
Thank you so much, Faye. I think that raises a lot of very fascinating questions to research further. We're going to move on right now so that we have time at the end for all the presenters to answer questions. Our next speaker is going to be Bradley Wagner. Bradley is a mathematician and modeler at the Institute of Disease Modeling in Seattle, and his work focuses on design of TB control strategies and quantification of their impact.
Well, thank you. Thanks for the opportunity to speak here. So this is going to be a little bit different in that this talk doesn't directly address social support, but it does deal with some issues indirectly about patient access to care and health-seeking behavior. The basic idea here is the focus on missed populations and populations that don't access care. And by definition, these populations are missed, which makes them difficult to quantify. But what do we know about these populations? Well, we do know that these populations contribute to transmission. So the idea here is, can we take a mathematical model and the population level data we have, the epidemiological data, generally incidence and case notifications, possibly prevalence, and can we actually work backwards to infer what health-seeking behavior is? So what populations are missed, the proportion of the population that's missed, or equivalently, the rate at which individuals seek care. So in our model, we broadly classify health-seeking behavior patterns into two classifications. Chronically missed individuals, and these are individuals that they may have low access to the healthcare system, or they may actually be accessing care but just not screened. So these are individuals you could think of as typically not being represented in our studies of care seeking, such as self-report data. Alternatively, we have individuals that are, if symptomatic, you would consider to be regularly screened. So these are the individuals you could think of as being represented in care-seeking studies. And if you look at these studies, you generally see median times to seeking care of weeks to months based on self-report from symptoms to first access to the healthcare system. So clearly, even without modeling, we can see that we know that the effect of TB interventions is going to be very different depending on what the makeup of our population is in terms of these two very broad classes. But moving on to the modeling part, well, how can we actually use our mathematical model to infer this information about missed populations? So what data do we have? So I already mentioned our epidemiological data, typically our case notifications, our disease mortality. This is just population level data that we collect, routine data. We also may have prevalence surveys. I'm not going to focus on that initially because I'm looking in South Africa, so we don't have that, but we'll come back to it at the end of the talk. So what else do we have in our model that can go feed into our models to give us more information? Well, we have other programmatic data, treatment success, loss to follow-up, diagnostic algorithms, we can implement with and translate their sensitivity from clinical trial data, as we often do, and we also know a lot about the natural history of disease. So how do we actually model this? Well, the model we use is an individual-based TB transmission model, and this is a country-level model for South Africa. So just a brief background, the model reflects the age population pyramid. As well, it's parameterized for TB and HIV disease progression. It tracks ART coverage that we know in the population are our best estimates of it. And it also tries to reflect as much as possible the TB care cascade. So those are sort of what we consider our better known parameters that we take from programmatic data. What about our unknown parameters? Well, care-seeking rates, obviously, that's the focus of this, but also infectiousness we know very little about. So these are also what are calibrated parameters. So these are the parameters that we allow to be free to actually to figure out what the best parameters are, best set of these parameters that matches the epidemiological data, our case notifications and our disease mortality. So just a quick note on the care cascade. We represent it in our model as passive case finding. So individuals present to the primary health care center. They may get a gene expert. That if they test positive, they can then initiate treatment, and you see there's loss to follow-up, losses at every stage, and we try to parameterize as close as we can to the data that we have. So how do we include the heterogeneity? I talked about these different groups of access and care. So we include heterogeneity as sort of a low access and high access, with low access essentially representing 35% of the population and high access 65%. We do allow the parameters, the rates of these parameters to vary independently though. So in the end we can analyze what the relative proportion of low access to high access is. So unfortunately this seems to be a bit cut off, but what you see here is WHO data for incidence, TB incidence estimates, and TB mortality estimates, the black dots being the most likely and the error bars representing the high and low estimates. And in the blue data you see is actually output from our model of our best fit to the data. And just the take home from this is that our data matches fairly closely to our output of our model matches fairly closely to the data going through all the high and low estimates. But we don't just want to know if one parameter matches fairly closely, we actually want to know what the whole range of parameters is. So here you see in this space basically a likelihood plot. And here what we're representing is the average time to seeking care of our two groups. The 65% group on the y-axis and the 35% low access to care on the bottom axis, on the x-axis. So as these dots get bigger, this is associated with a higher likelihood. It's also represented by color. And what you'll notice is what the model selects for is a fairly, what the model selects for is a fairly short time to seeking care in the majority of the population, but in the 35% group, you see a fairly large band along the bottom of the plot of likelihood. So really times here could range from a few months to even a few years, and we can't distinguish among these which it really is just from this data. So we can look at this a little bit better in terms of distributions. And again, this is basically recapitulating the same data you saw before. But the first distribution is the distribution of the low access. And you see, again, a large spread between 0 to 2,000 days. Whereas for the high access at the bottom, you see it's fairly focused and with its most likely at a few months. So what we're actually recapitulating is essentially what you might see from self-report data. And on the right, what you see is the two-dimensional plot of distribution of the two parameters. So lastly, looking at prevalence, Well, prevalence is the one thing that we did not have to calibrate with, but we can look at it as output from our model. So what you see in the top is the prevalence from our best fit. What you see at the bottom is a comparison at 2 time points, 2010 and 2015, between between our most likely, which actually was had a value of I didn't mention this, had a value of a few hundred days in the high access group and about a few years in the low access group, versus something more homogeneous where the access is around the order of a year for both groups. And as expected, what you see is a difference in prevalence of about 3 to 400 per 100,000, being lower in the second group. So what this implies is actually, if we could do the same analysis having prevalence data, such as the prevalence survey, we could actually narrow in a lot more and eliminate a lot of this parameter space and narrow this down quite a bit. So to conclude, our models are actually consistent with a majority population seeking care within months of symptoms that you might get from self-report data, but at the same time, there's much uncertainty, and I should note we can't rule out just by case notification data and mortality alone that there isn't a significant chronically missed population. So lastly, prevalence data could reduce the uncertainty substantially in our ability to infer care-seeking patterns. And lastly, I should say, this has all been an indirect way of looking at things to try to quantify something. It's always great to have actual direct data out of a prevalence survey where you could actually see what the correlates are of care seeking. But I think in the end, if you had that and could combine that with a model, you could get extra power to be able to really improve your quantification and reduce uncertainty. And just some future work, we're looking at this in terms of subnational models at the district level with more complexity and better representation of our healthcare systems. Thank you.
Thank you, Bradley. I want to congratulate you on finishing in exactly 10 minutes. So we're going to move on to the next presentation. I think that raises a lot of interesting questions about the implications for policy on active case finding and how much time and resources we spend on that versus getting people through treatment. Our next speaker, Erez, are you here? Yes, okay. Erez Yali is a social scientist at Yale University working in the Applied Cooperation team. He teams up with government agencies, nonprofits, and for-profits to design and test interventions to promote cooperation in real-world settings, including charitable giving, volunteering, energy and water conservation, smoking ban compliance, and medication adherence. And Erez is going to talk about self-verification and behavioral interventions via mobile phone, drastically improving tuberculosis treatment success in a randomized controlled trial.
Thank you. The project today is focused on the following question: can we deliver a behavior change intervention over mobile to promote tuberculosis treatment success? The project is a collaboration between Kahila, a mobile health startup founded by John Rathhauser. John, raise your hand. And the Applied Cooperation team, which is a consortium of academics based primarily out of Yale, who are mostly economists and psychologists interested in taking things that they know about the science and using them to actually change behavior in real-world settings that we care about. When we teamed up, our goal in designing this intervention was to motivate and assist patients as they underwent treatment, not just to cause them, not just to monitor them as they underwent their treatment. To do this, we decided fairly early on that we would frame adherence not just as something that was good for you, but also something that was good for the public good more generally, something that was good for society. That by taking your medication every day and by completing the full treatment, you are helping your community and the people around you. The reason that we did this was because it opened up for us a large category of social science interventions that have been used in other contexts, like promoting resource conservation or getting people to give more to charity or to volunteer more, These social science interventions have been shown to be very effective in those contexts, and we wanted to draw upon them to try to motivate people in our own context here to adhere and to complete treatment. More specifically, we decided to build a mobile phone platform that worked over USSD, which meant that it would work both on smartphones as well as flip phones, which are ubiquitous in contexts where tuberculosis rates are high. That for us was a means to an end. It was a way of getting this intervention into people's hands without requiring a lot from the healthcare infrastructure, without requiring a lot from patients themselves. We wanted to simply get this out there using what they already had. The platform had the following 3 key features. First, we gave patients a reminder every morning to take their medication, and we asked them to verify that they had taken it. Second, we provided some accountability and support. What does that mean? Well, if the patient didn't verify, they got a reminder. If the patient didn't verify, they got another reminder. And then eventually, if they didn't verify a third time, somebody actually followed up with them from our team of supporters and asked them, hey, what's going on, and tried to sort of engage with them and bring them back into the fold. And then the final third piece of this platform was simply to provide them with motivation, text messages that tried to engage them and make them feel like they were part of something bigger and part of something good. Finally, last thing I want to say about the platform itself was that it was designed with a team of local survivors and then supported by that same team so that we could make this thing as culturally appropriate as possible and really address the challenges that the individuals we were trying to serve had, and then to provide the support in the same way. All right, a little bit of details on the pilot. This is a year-long pilot funded by USAID during 2016. The pilot took place in Nairobi. There were 17 partner clinics all over the city. We ended up with 1,200 patients that we split into 2 groups. The intervention group would have access to this platform that I just described, and the control group retained the standard of care. Our primary outcomes are whether you successfully completed treatment, i.e. LTFU, D, and F, being the unsuccessful treatment outcomes, and also, of course, we can look just at LTFU by itself. Our secondary outcomes that we'll look at are actual verification rates on the platform, which we can do, but of course only for the intervention group. So some results. First of all, does this thing work? So here are the unsuccessful treatment rates by intervention group. In the blue bar, you see the unsuccessful treatment rates for the control group, which is roughly what you would expect to see in Nairobi historically. And in the red bar is the unsuccessful completion rate for the intervention group, which is just under 5%. I can look at these numbers by smear positive only. I can look at these numbers just for LTFU, and no matter how you look at the numbers, you will find that the difference is quite big and statistically significant, at least at the 5% level. I can also run regressions to control for patient characteristics, and the estimated intervention effect is robust to those controls. The second question that we can address is, for whom did this intervention work best for? And one of the things that we found very interesting was that the intervention seemed to work particularly well even for those folks who are traditionally underserved by the healthcare system. Let me show you what I mean. So in front of you, what you have is unsuccessful treatment rates for folks based on whether or not they were HIV co-infected, and also for folks based on their gender. And what you can see is that the unsuccessful treatment rates are higher for folks who are HIV co-infected, as you might expect. They're also higher for males. And then if we look at the unsuccessful treatment rates in the intervention group, then what we find is that regardless of where folks started out, we're able to get them roughly to the same level. Now, I can do this in a slightly more sophisticated way that takes into account all of a patient's characteristics at once. So bear with me for a second as I describe that. What I'm going to do is I'm going to predict how likely someone is to not successfully complete treatment just for the control group. And then I'm going to apply those predictions to the treatment group, the intervention group, and that allows me to say, had this person not received the intervention, how likely would they have been to fail? And then I can use that number in a variety of different ways. So let me show you one way in which I can do that. Here you have a chart where I've taken folks and I've split them out into different quintiles based on how likely they would be to fail, based on that prediction that I just described. Folks on the left are the folks who are predicted to fail with the least likelihood, and folks on the right are the ones who are predicted to fail with the most likelihood. And I'm presenting the actual outcomes for the control and the treatment group separately. What you can see is in the control group, as you would expect, the unsuccessful treatment rates go up and up and up as we move from the left to the right. But in the intervention group, they basically remain constant. So what that means is no matter how likely you would have been to fail, we're able to keep you at roughly the same rate. All right. The next result I want to talk about is whether individuals verified. So I'm going to switch from talking about the primary outcomes now to verification rates on the platform. And the answer is yes, they did. Here's a histogram of verification rates. Over there on the left, you can see that there are about 12-13% of people who basically never verify. Those are folks who aren't really using the platform. They may still be using its reminder feature, but they're not using it to self-verify. But then basically everybody else has at least some verification going on, and there's a big mass of folks over here on the right who are using it pretty intensively. The average verification rate on the platform is in fact 60%. The only comparison I have one study that I managed to find that reports verification rates in a two-way SMS system, and in their study, the reported rate was in the 20s. So we're doing much better than in that study. And then the final thing I want to talk about is the relationship between verification and treatment success, i.e., do we see that people who verify more actually succeed more? The way that I'm going to do that is to return us to that prediction that I talked about earlier, i.e. how likely people would have been to fail had they not received the treatment. And the question I'm going to ask is, does the gap between that predicted outcome and the actual outcome grow as people use the platform more and more? So here you go. On the left-hand side, those are folks who use the platform relatively little. On the right-hand side, those are folks who used it a lot. What you can see is that their predicted failure rates are fairly constant, but the gap, their actual failure rates are dropping, and so the gap between the two is growing as they use the platform more intensively. So it looks like verification is related to success. All right, so this is a experiment with only 2 arms. I don't really know what particular piece of the platform worked, but I'm going to try to guess anyway. So number 1, the fact that we built this thing and supported it with a team of folks who really understood this problem, I think was critical to its success. Number 2, the fact that we were able to provide that support in a very timely way, in a way that was convenient for people, I think is also critical. Just compare to the standard of care where the first indication you get that somebody has stopped taking their medication is when they show up to the clinic, when they fail to show up to the clinic on their weekly visits. And we're able to do that in a matter of hours rather than a matter of weeks. So we're much quicker at getting people the support that they need. And then finally, I think the fact that we went into this with the approach that we did of using behavioral sciences to make this platform really engaging and to try to get people so that they're using it intensively and really motivated to be a part of this bigger thing, I think probably helped to increase our verification rates and usage rates relative to other platforms that have tried to do two-way SMS. Thank you very much.
Thank you very much. That was a really fascinating presentation, and I hope we have a few minutes to discuss afterwards. We have our last presenter now. Our last presenter is Dr. Sarah Brown. She is the Associate Professor of Medicine at University of California, San Diego in the United States in the Division of Infectious Diseases, and she will talk about a wirelessly observed therapy modality that is accurate and confirms more TB medication doses than DOT.
Hello, thank you very much to the organization for giving me the chance, giving us the chance to present our work.
I have no disclosures. I represent a team of academics from the University of California, San Diego, the University of Florida, and the TB program control from 2 Southern California counties. This work is dedicated to Thérèse of Lisieux, who died of TB at the age of 24. What's the background? The background to this work is that if you have successful treatment, we need a combination of both good diagnostics, with hopefully genomics backed. We need effective drugs, we need good drug availability. And we also, because of the complex nature and the long nature of tuberculosis treatment, really need good treatment adherence monitoring and support. The gold standard of tuberculosis treatment monitoring and support is directly observed therapy. So what that means, I'm sure the entire audience here knows what that means, but it is when the healthcare worker watches a patient swallow their medication. Now, the WHO and the CDC, of course, recommend DOT. This is the gold standard. It is resource intensive. It is inconvenient. It can be intrusive to patients. It's actually very complex to administer and implement. And even in high burden even in very highly resourced settings, this is still done with paper records. It may well not be feasible globally where you have smaller public health structures and not enough personnel. In addition, it's very difficult to do across large geographical areas, even in highly resourced settings. I'm at the University of California, San Diego. In San Diego, we have 8 TB nurses and 8 dot workers covering a 4,500 square mile area. Now, for a lot of people in this room, that looks pretty good. But I can tell you that it is still difficult to do a highly effective DOT program over that geographical area with that number of personnel. So we're working with a potentially breakthrough technology known as wirelessly observed therapy. So this is the very first technology that allows the time and date stamping of actual medication ingestions. This technology was developed by a Silicon Valley company called Proteus Digital Health. And it uses an edible ingestion sensor. The patient is required to wear a patch, and that patch is paired to a mobile device. One of the most amazing things about this technology is this tiny little edible sensor. That's the size of the edible sensor. It's 1 by 1 by 0.45 millimeters. It is made of metals and minerals that are excipients in food and vitamin pills. It has an active layer, gold layer that acts as a current collector. So how does wirelessly observed therapy work? When you have a medication that has been digitized, so this is a new piece of language, but we call this digitized medication. When a medication has been combined with a sensor, we call it a digitized medication. When that medication is ingested with the sensor, when it hits the gastric tract, sorry, I'm not fast enough. When it hits the gastric tract, the sensor readily separates from the medication, and there's an electrolyte change in the gastric solution which issues a pulse. That pulse is recognized by the patch worn on the patient's torso. Each chip carries a barcode, and the patch recognizes that barcode, and information in that barcode can include drug batch manufacture, dose, as well as the time and date of that ingestion. So the patch stores all that information until it comes into proximity with a paired mobile device. And then from that paired mobile device, when that device is in regions where you have cellular connectivity or Wi-Fi, it can be uploaded to secure servers. This data handling is a very important issue. So I said that the data is automatically uploaded, and it has to be secure, so this data is sent wirelessly by encryption, similarly to that used in the banking systems. And what can a designated device be with this system? It can be a smartphone, but this system can also work on a standard feature cell phone as long as the standard feature cell phone has Bluetooth capability. So this is the Watt information flow. You have a digitized tuberculosis medicine. It's ingested. The sensor separates, issues its barcode signal. It's recognized by the patch. The patch stores it. When the patch is in proximity to its paired mobile device, all the data from the patch is uploaded to the paired mobile device. When the mobile device is in a cell phone area or a Wi-Fi zone, it is lifted through the existing structures to a secure servers. So what does this mean? It means that a healthcare worker can access, if they have the right permissions, can access data on any instrument that gives them access to the internet. And they can look and see whether their patient has ingested the medication. These are some visuals that I'm going to flip through very quickly because of time. Before we started doing these trials, we knew that the sensor was very safe. The system had been approved by the FDA in the US and was CE marked in Europe. We knew that there was some self-limited skin rashes associated at the patch site. And what needed to be done was we needed a combination of the sensor with a tuberculosis medication. And so what we did is we developed a combination of the sensor with a fixed dose, isoniazid and rifampin. So we digitized isoniazid and rifampin. And then we also conducted a PK study because this had never been used in active tuberculosis patients before. And we wanted to make sure that the combination with the sensor didn't make any difference to the underlying medication. And that bioequivalence study, we showed that the two were bioequivalent. And there is an article at the bottom of this. It's called Digitizing Medicines in Clinical Pharmacology and Therapeutics. It is e-published ahead of journal publication. And if you want to read more about that, you can look at that journal. What is this great combination we made? Well, here it is. It's co-encapsulation. So it is, what we did was the rifamate is in red. The tiny little sensor that you saw in that one photograph, the company produces these small little white pills that contain that tiny sensor. So what we did was we put it into certified gelatin capsules. So everybody here is familiar with placebo-controlled trials. So this is exactly the same as that, except we're putting the sensor in. For that reason, we're calling it co-encapsulation. And it can be done, it's a repackaging step, it can be done by pharmacist technician, it's very easy, and the GMP for that is in that publication that I listed. So we thought that we had a potentially groundbreaking new tool that was very relevant to tuberculosis. And we wanted to design a rigorous trial so that we could actually evaluate this. And we did it in 2 phases. So before we could start working in patients, we needed to know whether this thing was actually accurate. It had not been used in tuberculosis patients before. And we needed to see whether it had some clinical utility to it. So what I'm going to be talking to you about today is the phase 1 of this clinical control trial. Okay, so we did a phase 1 of the trial, attempted to assess the accuracy of the system. We derived something called the positive detection accuracy. We had patients who were binationals living in San Diego on this, working in San Diego and living in Mexico on this trial. DOT was given 5 days a week. Everybody in phase 1 had both wirelessly observed therapy and DOT at the same time. So the healthcare worker was watching the patient swallow the digitized medication so that we could work out exactly how accurate this was. We also calculated the total number of doses confirmed by wirelessly observed therapy as opposed to what. There were 75 patients who completed the study. These are the demographics, and we had a low adverse event rate. What turned out to be highly accurate, the positive detection accuracy, was 98.5% with a very narrow confidence interval, and with these kind of figures, we consider wirelessly observed therapy equivalent to DOT. Then we looked at the total number of doses over the period of observation to see how many doses were confirmed by Watt versus DOT. So we know that Watt's equivalent to DOT. Now we look at over the number of days, how many doses were confirmed. And it turned out that Watt confirmed 50% more doses than DOT. How is that possible? DOT is only available during business hours, and so it doesn't cover weekends and holidays. These are some of the examples of some of the output you can see from a patient watt record. I apologize, I'm over time, so I don't have the ability to show you more. This is a highly compliant patient. These are individual ingestions of the medication. Here's a patient that would need more adherence support, so you can use this technology to look at patterns and you can support adherence. So conclusions, from phase 1, what was equivalent to DOT? It confirmed more doses. We were able to do remote adherence monitoring in near real time. It was accurate, safe, and potentially clinically useful. Why do we think this technology has the potential to transform TB treatment? So wirelessly observed therapy works on existing cellular networks and internet infrastructure. It doesn't require a lot of personnel, and it can cover large distances. It's highly relevant, if appropriately adapted, to countries that lack medical personnel and a large public health infrastructure. There is no limit to the number of patients you can observe with what. The other thing is that this system immediately digitizes adherence data. So you have digital records, which means that you can provide digital summaries of everybody on the program, what medication they're taking and whether they took it or not. By this stage, we have completed the randomized trial in the US of Watt versus DOT. That data wasn't ready for this meeting, but it's been submitted to CROI, and we'll see if they give us the chance to talk about it. We think that further clinical trials are needed in diverse global settings to evaluate this technology. I apologize for going over time. We want to thank the participants who loved the technology. The San Diego team, we've got Dr. Constance Benson, who some of you may know well. Amanda Tucker, Jonathan Gonzalez-Gonzia is here. He looked after the binational patients. We had amazing collaboration with San Diego County. Nothing would have happened without the collaboration of San Diego County with Dr. Moser and then Julie Lowe. Proteus Digital Health supplied the technology, and we were funded by not-for-profits in San Diego whose mission is to care for people of low income and most in need. Thank you very much.
So we have about 6 minutes for questions. If anybody has questions to ask, and Sarah, before you leave, I wanted to ask you a question about the potential cost of this technology right now, and patient acceptability, and whether there were issues around that.
So the cost, the company donated the technology to us, so we don't know what the cost is. Orange County is currently doing a cost analysis, and that is ongoing. We also have economists who are global economists at UCSD looking at where the price point is going to need to fall for this to be relevant in middle and lower income countries. And the other question was? Yeah, so patient acceptability, we do have data on that, but we're only going to do with the phase 2 data. All I can say is that we can't talk about the phase 2 data at this point, but after phase 1, no one wanted to be on DOT. That's the only thing I can tell you about the acceptability.
All right, thank you very much. Do people have questions for either Sarah or our other presenters? I have plenty of questions, but I want to give you all a chance to ask questions. Okay, I wanted to ask a question of Erez, if you don't mind. So I think those are really very interesting data, and I wondered, first of all, in terms of, you talked about follow-up of patients who didn't verify, and I was wondering if the team did that by phone, by personal contact, face-to-face, or how that went. And then the second question, what training did you give to patients to be able to use this system, and was that easy for them to do, or did you find that people had trouble?
So the first question so the second question was training, the first question was follow-up. Okay, so the first question about follow-up was, the way that we did this was we had the support sponsors, the team that you saw in the photo. At first they started by texting, And they typically would text once to a few times, depending, it was sort of up to them, before attempting to contact by a phone call. And then if several phone call attempts didn't work, then eventually we would refer this particular patient to the clinic and let them know that we were unable to reach them so that they could potentially attempt to use the existing infrastructure to contact them in person. The second question on training, it was fairly lightweight. So the the individual was onboarded by one of the support sponsors who explained sort of the goal of the intervention, but also sort of explained roughly how it would work. And then there was a short tutorial once the individual had been assigned to the control group. And because this is a platform that's built on USSD, which is the same platform that M-Pesa and other payment platforms are built on, and these are fairly ubiquitous in the region that we were operating, it was completely intuitive for most of our users.
Yes, question over there.
I have a question while you're here. That was very, very interesting. You started out saying that one of the real motivators for this was getting people to appreciate that they were contributing to their community, not just to themselves. What language and how did you insert that into the messages, and where did that appear in this intervention?
The short answer is everywhere. When we sat down to build the platform with the support sponsors, we explained to the support sponsors that that was our goal. And so it started even with the onboarding, the in-person onboarding, where the support sponsor would speak about this as a problem where you were contributing to the whole community and you were part of a community that was doing so. We also even handed out a little wristband that said "Health Hero," "Shuja wa Afya" is the phrase, and Shuja in Swahili actually has like nationalistic connotations. And this was language that we developed with the support sponsors. And then it showed up everywhere from the actual messages and the way that we asked people to verify to the extra messages we sent to do motivation. And I'm happy to sort of show you examples of those, to the way that the support sponsor would speak to someone, and even just like in the way that we thought of like, what does it mean to be somebody who's complying with the request? So we used theoretical research that showed that people think about this as a very categorical thing, to make sure that our requests were categorical, something that someone might not even notice if they weren't sort of looking for this in the platform. So it was really like pretty fundamental and throughout the platform.
Thank you very much. And we're pretty much out of time now. I have many questions I could ask all of our speakers. I thought all of your presentations were very thought-provoking, and I just want to say that I'm really so appreciative of these sessions where we get to talk about less of the drugs and more of the other components that go into successful TB treatment. And so I really want to thank all of you for the hard work that you've done in this area and for the very interesting work that you continue to do. And I wish you great success in the work that you're working on right now. And on behalf of myself and Dr. Sandoval, I would like to say thank you to all of the participants for your attention, to the speakers for keeping to time, and I hope that we have more time for discussion next year.
Many congratulations to the speakers.
Music.